I'd like to welcome everyone to the Senate Committee on Rules, Government Ethics, and Oversight for Monday, March 22nd. Jamie, can you please take the roll?
Chairman DiPalma.
Here.
Senator Seveny is here. Senator Coleman.
Here.
Senator Acosta.
Present.
Senator Dela Cruz.
Here.
Senator Oyer.
Here.
Senator Lombardo.
Present.
There are 7 members present. There is a quorum.
Thank you, Jamie.
Mr. Chairman, if I may, I'm present as well. If I could be recorded as being here, Stephen Archambault. Thank you.
Senator
Sorry,
Archibald.
Senator. I missed you there.
There he is. He's down the... Senator, good to see you. For the record, and he'll be filing the appropriate paperwork, Senator Chacon is filing a paperwork for recusal given his relationship with the topic. So Senator Chacon would have been here, but he's filing a recusal on the topic. I want to thank everyone for being here tonight. We have several folks in the public who will testify at the end. I just want to give a few opening remarks and get right into the heart of the matter. Tonight's topic is, as it indicates, the overview and current status of the Eleanor Slater Hospital system. And we'll get into it, and we'll have the Secretary Director and her team talk to us about that. What we will not talk about tonight are finances. We will not talk about funding. We will not talk about things associated with that. It may come up, but our primary focus of tonight has to do with the patients at the Eleanor Slater Hospital. Those on the Zambarano campus, at Regan, at Adolf Meyer, at the Benton facility, those in Burrillville on the Zambarano campus. First and foremost are the patients. That's why we're here. That's why this hearing has been called, to understand and appreciate the facts and the data surrounding the situation. For some individuals, this has been the entire life, where they've lived their entire life, potentially their adult life maybe. For others, they've been there a short period of time. We've heard questions and stories with regards to folks who have been admitted, not admitted, discharged, not discharged, discharged to certain places, not discharged to other places. The goal of tonight's hearing is on gathering facts and gathering data on the Eleanor Slater Hospital system. The patients that are there, the Rhode Islanders that are there, could be our brother, our sister, our mother, our father, our aunt, our uncle, our daughter, our son, our grandmother, our grandfather. I think I covered all the relations that are potentially there. And for them, this is the place of last resort. This is the place where they've lived their lives, where the only place they can go, as it currently has stood for them for decades or maybe a short period of time. But at the end of the day, tonight is about fact-finding, about understanding and appreciating what we currently have in the Eleanor Slater Hospital system. And as we move forward, what are those gaps? I think we'll come over here tonight, and moving forward from here, what are the gaps in the Eleanor Slater Hospital system? What are the gaps in that treatment and the care that's given to those patients that we may still have a gap moving forward from March 22nd, 2021. So our job here tonight is fact-finding, it's data gathering, it's about ensuring when we walk away here tonight, there will be some actions. There'll be some additional questions that will be left unanswered. With that, I want to welcome Secretary Womazetta Jones, Secretary of the Executive Office of Health and Human Services. I had previously sent the Secretary a letter, as I do for all of our oversight hearings, to all the folks who will present, articulating the kinds of things we're looking for. I'm a firm believer in being respectfully direct, articulate what you're looking for, enumerate the items you'd like to see and have covered, and I think the Secretary and her team will walk us through that tonight. It's our job as legislators on this committee and the public who's watching to understand and appreciate, when all is said and done, what is the story, and I say that respectfully, story in quotes, that the facts and the data are telling us. Based on that, we will then need to figure out and determine what we do next. With that, Secretary Jones, welcome. Thank you for being here with us tonight and your team for being with us tonight. I'd like to turn it over to you and have you take it from there. Also, just before you begin, Madam Secretary, for members of the committee, I would like to have us hold our questions to the end. This way, a question we may ask, including myself, I will try not to violate it. I've been doing good. I'll try and do better tonight. I may have a question. I want to ask that question immediately, and somebody's going to address it on the next page or the page after that. So I know it's hard, but we're going to have them walk through the entire presentation. We'll address questions at the end. Subsequent to that, we have approximately 20 folks or so looking to testify verbally. And we'll talk about that when we get there. If you're watching and you will be testifying, you could be thinking about it now. We have a objective of, if you can speak about 3 minutes, we have a threshold of 5 minutes. Given that we have 20 folks who potentially want to speak, some of those are going to be very heartfelt thoughts that they will share. May be difficult to do that in 5 minutes. So if you're listening to this, watching this, we will call you when it's your time. If you can please think about how do you keep your testimony between the 3 and the 5 minute mark. Madam Secretary, over to you.
Thank you so much, Chairman DiPalma, and members of the committee for an opportunity to address you tonight. My name is Womazetta Jones, and I am proud to serve as the state's Secretary of the Executive Office of Health and Human Services, also called EOHHS. And I'm so sorry, if you could just give me a moment. We have some feedback in the room that we're going to need to turn a speaker or something down in our training room. So just give me 1 second. Okay, thank you. I was getting a lot of kickback, so I apologize. But as I said, thank you all for having me and allowing me to address you tonight. I'm joined by my EOHHS Assistant Secretary, Anna Novice, as well as the BHDDH Director, Catherine Power, and her team. And I would like to start tonight with giving you a short explanation of the work of EOHHS. Under state law, EOHHS is designated as the single state authority for administering the Medicaid program here in Rhode Island. And we're also the executive branch's umbrella agency for the Departments of Health, Human Services, DHS, DCYF, BHDDH, OHA, as well as Veteran Services. By statute, the director of the Health and Human Service agencies are appointed by the governor with advice and consent of the Senate and serve on the governor's cabinet. The directors also have appointing authority for all of their employees and spending within their departments. EOHHS provides a variety of supports to the state's health and human services agencies, including but not limited to strategic planning, legal, financial management, policy guidance, data analytics, performance improvement, and technical assistance with matters related to Medicaid. As Secretary of EOHHS, I have 3 guiding principles on how my team and I approach our work, and they are choice, race equity, and community engagement. In terms of providing choice for all individuals and families, every resident we engage must be given a right to choose and influence the services they receive. We must also treat each person as a whole person, not just a specific situation or a specific dynamic, but we need to help as it relates to the whole person and treat each individual respectfully and ensuring that they're able to keep their dignity intact. One of the pillars of our work at EOHHS is that whether someone is receiving services through BHDDH, DCYF, DHS, RIDO, VETS, BHDDH, Healthy Aging, they deserve to receive the services that best meet their needs in the least restrictive and most appropriate setting possible. As it relates to race equity, we must ask ourselves every time we create a policy, a procedure, or begin to implement a plan, what role, if any, does race play in the decisions that we make? Are the decisions we're making equitable? Are they fair? And last but not least, we need to be committed to authentically engaging the community. We need to intentionally have community at the table from the onset and throughout an entire process. And most processes never end, they just continue to evolve. So community needs to be at the table from the beginning to the end. We must ensure that their voices are heard and that they are respected. We must also ask community what they need before we act. We have to stop assuming that we know what's best. We need to ask, we need to listen, we need to engage, and then we need to move forward. EOHHS also has strategic priorities that fall into 3 categories. One is to preserve and improve access to quality, cost-effective healthcare. The second is to shift systems and investments to prevention, value, choice, and equity. And the third, but not in any particular order, I may have said first, second, and third, but these are interchangeable, is to curb the opioid epidemic, address addiction, and improve mental health. With regards to the future plans for Eleanor Slater Hospital specifically, EOHHS has provided BHDDH with similar supports based on the needs identified by BHDDH and the previous administration. One example is how EOHHS, the Medicaid program, has worked extensively with BHDDH to submit a state plan amendment, often called the SPA, to the Centers for Medicare and Medicaid Services, usually called CMS. If approved, it will allow Eleanor Slater Hospital to receive federal reimbursement for some of their services. We are currently awaiting word from CMS about this SPA approval. While there may be a variety of strategies and opinions about how best to approach this issue, the future plans for Eleanor Slater Hospital are aligned with EOHHS's guiding principles, strategic plan, and federal law, which says that individuals legally deserve to live in the least restrictive setting possible. Everyone deserves to live and receive support in the least restrictive community setting for their individual needs, whether that's a hospital, a nursing home, a group home, or if at all possible, with the family, with their family, in their home where they grew up. Governor McKee is committed to keeping Zambarano open and continuing the transformation of the Eleanor Slater Hospital system to ensure that Rhode Islanders receive the most appropriate level of care. In the FY22 budget proposal, the governor recommends construction of a new long-term care facility on the Zambarano campus, estimated to cost about $65 million and financed with certificates of participation debt financing, of which $53.6 million in new borrowing is requested. He also recommends closing and consolidating our state's aging long-term acute care hospital facilities, and the creation of a standalone institute for mental disease at the existing Benton facility. The state of Rhode Island must fully commit to deinstitutionalization. We have to commit to that. While the staff at Eleanor Slater Hospital provides amazing care to their patients, most people do not belong in a hospital setting long term. Director Power will provide details, but we have patients at Eleanor Slater who have lived in that hospital setting for decades, although they might not have needed that level of care. Remember, we have to be fully committed to deinstitutionalization. We have to be committed to it. Let me be clear. Director Power and her team believe, as do I, that no one should be discharged from Eleanor Slater Hospital without a comprehensive discharge plan in close consultation with patient, the family or their guardian, and providers. The future plans for Eleanor Slater Hospital will align Rhode Island with national healthcare delivery best practices by treating individuals with shorter lengths of stay, shifting treatments to comprehensive health services in community rather than in restrictive settings. We will also mitigate the serious ligature and safety issues we see in our older facilities. Director Power has been clear that if it is determined that a patient's individual needs require hospital level of care, they need to stay at Eleanor Slater. They will continue to reside and receive care at the hospital. The director of BHDDH serves as the governing body of Eleanor Slater Hospital. Director Power and her team manage the day-to-day operations and direct patient care at the hospital. BHDDH is also recognized at the federal and the state level as Rhode Island's mental health authority. Therefore, I have asked Director Power to lead tonight's presentation and discussion. I thank you very much for being here, Director Power. And in a moment, she will walk us through some slides regarding Eleanor Slater Hospital and related topics as requested by the chairman. Chairman DiPalma, as I conclude my opening comments, I want to take you up on an offer that you always make me every single time we talk on the phone, a gracious offer. You always say to me at the beginning, the middle, or the end of a conversation, tell me how I can help you, Secretary. I want to take you up on that. Policy decisions with major implications like the needed changes at Eleanor Slater Hospital are far-reaching and extremely complex. EOHHS, we stand ready to support and provide guidance and oversight necessary to ensure the successful system transformation, but we recognize that this is only the beginning of a very long journey as we work together on the path forward for Eleanor Slater Hospital within our Rhode Island's healthcare landscape. I welcome the General Assembly's partnership in solving these issues and in building a stronger, more efficient, and streamlined secretariat. This is a marathon, it's not a sprint. And we need everybody's input, everyone's help. I want to go back to my pillars as it relates to choice, race, equity, community engagement. That's what we do, that's what we must do, and that's what we got to do. So I now would like to turn it over to Director Power and her team. And I thank you all for your time this evening as we have, I'm sure, answer many difficult, questions, because this is a hard topic. These are people, their lives, people that we care about, people we're committed to. We're in this work because we know we were put on this earth to do it, not to be in any other type of role except for that of helping people. So I thank you, and I pass it over to Director Power.
Thank you very much, Secretary. Want to say hello to everyone on the committee, and good afternoon, particularly Senator DiPalma and members of the Senate Rules, Government Ethics, and Oversight Committee. And I really want to thank the chairman for addressing this issue and for laying out the parameters under which we will talk about this very important issue tonight, and for all of your interest in the Eleanor Slater Hospital. I appreciate the opportunity to provide you with not only an opening statement, but also just a short series of informational slides that really articulate some of the answers to the questions that the chairman put forward. And we've also been able to then to reiterate some of the ideas that we've put forward to the legislature that talks about how we believe we're putting our patients first. I'm really pleased to take this opportunity now to shed light on the extensive clinical reviews that the hospital has undertaken to clear up some of the public misunderstandings about the hospital's discharge process. First and most important, I strongly believe that I, as the director, and that we as a state must continue to put the patients at Eleanor Slater Hospital first in our decision-making and first in our care. The needs of the patients at Eleanor Slater must drive the decisions related to their ongoing care, and at Eleanor Slater or in any other facility, these care and treatment decisions should not be made on the basis of any other factor other than what the patient needs to be well and to thrive. The plan the administration offered to the General Assembly Finance Committees last fall, when I appeared before the Senate Finance Committee and the House Finance Committee on the Subcommittee of Health and Human Services, and I reiterate to you tonight, now does exactly that. As we assess what our patients need, we are offering a plan that supports ensuring our patients' continued wellness and safety. Further, decisions on discharge from the hospital must be made exactly the same way, by determining what our patients need in conversation with them, in conversation with their families, in conversation with their guardians, and using that determination to understand what kind of care will support their long-term well-being. We knew that changes had to be made due to a confluence of events, not the least of which is the changing healthcare environment. The Rhode Island General Assembly commissioned a state hospital in 1869, and it opened in 1870. When this department was created in 1962, the state hospital would become part of what was then known as MHRH, the Department of Mental Health Retardation in Hospitals. And healthcare looked quite different in those days. The change in our name alone hints at the tremendous shift between our attitudes then and now about some of our state's most vulnerable people. Not very long ago, we often put individuals with intellectual and developmental disabilities and people with significant behavioral health challenges into institutions, out of view, without regard to what would help them enjoy life in a supportive community. When I was the director of this department from 1993 to 2003, we closed the Ladd School. When we moved the last of the residents out, it was a unique and joyous time in Rhode Island's history. We believed that the culture of institutionalizing individuals was over, and that everyone would enjoy the benefit and conviviality of living in a community. We would never imagine that some who live with treatable mental illnesses would still be institutionalized almost 20 years later. Changing attitudes in having people live in the community continues to be a work in progress, and a hard work in progress. While we've made significant progress in helping some of the most vulnerable Rhode Islanders experience the joys of life in a community with appropriate supports to assist them, we still have a lot farther to go. Eleanor Slater Hospital represents the next step in truly realizing our collective vision of supportive communities that help all of us, every single Rhode Islander, thrive to the best of our ability. I always said that no one should live their life in a hospital. With new medications, with care coordination, and with group homes and assisted living environments, there is absolutely no reason an individual can't live in the community, as long as they are deemed able through a comprehensive review and discharge process. Look how far we have come with individuals who have a developmental disability. They are living and working in neighborhoods across the country. There are many more supports and resources available to all those who have a disability, regardless of whether it's a developmental or a behavioral health disability. I want to be completely clear and especially repeat, we have not, and we will not, discharge any individual from Eleanor Slater Hospital unless they and we are confident together that they can get the support they need to succeed in a new setting. Nonetheless, we have an obligation to look at what our patients need and to make plans with them, their families, and their guardians for their long-term well-being. This is all we are trying to do, to put the patient first by understanding what they need and by giving them, frankly, the opportunity to think about living under different circumstances. There are individual patients who have said, no one's ever asked me if I ever wanted to live someplace else. Unfortunately, in other ways, our hospital is stuck in the past. Over time, a few healthcare changes have occurred to bring the department up to date with some current trends. However, in the last 10 to 20 years, the environment has rapidly changed. and it's become much more sophisticated, much more complex, with the development of managed care entities and accountable entities, with the development of sophisticated electronic medical health records, which would provide comprehensive data analytics, and with the redesigns of hospitals to provide better care. Even CMS today no longer issues LTCH licenses to hospitals. Statewide, we have seen health incomes improve because of this sophistication. But Eleanor Slater, as a part of a state department, is performing work not far from where we were in 1962. A paper medical record is all we have. We have no data analytics, and many buildings have simply not been upgraded. Financial stability has also changed. Put bluntly, the hospital cannot bill Medicaid for half or more of its cost as it has in the past. A thoroughly outdated and discriminatory federal rule called the Institute for Mental Diseases IMD Exclusion has long posed a significant challenge for Eleanor Slater Hospital and others like us. This rule prohibits any facility with more than 16 beds to bill for individuals between the ages of 21 and 65 receiving psychiatric care if you don't have more medical patients than psychiatric patients in that facility. Today, in 2021, with the Affordable Care Act and federal mental health parity legislation, a facility cannot bill Medicaid if providing medically necessary treatment simply because that treatment happens to be mental health care. This exclusion directly contributes to the negative perceptions and outcomes for those living with mental illness. Furthermore, the hospital must adhere to other restrictive guidelines when billing Medicaid, like ensuring that we cannot charge Medicaid for services provided for forensic patients. These rules and others have created significant financial instability in hospital operations under the hospital's old billing model. The creation of a new facility at Zambarano is proposed to help us navigate some of these challenges. We think that creating a new facility at Zambarano provides more clinically appropriate care for patients, and that will allow us to claim Medicaid reimbursement on the services that will be provided there, mirroring facilities in other states, even as the Benton Center will remain a forensic hospital, which can only be supported by general revenue, a model that is also consistent with forensic hospitals in every other state. Moving toward this plan will provide us with the best structure of patient-centered care for present and future parents of Eleanor Slater Hospital. I want to now move to emphasize some of the data input that the chairman had asked us to provide, and Ryan Erickson is going to help queue up just a few slides for me to go through some of the information that the chairman asked for us to be able to go through this data request. And in fact, Mr. Chairman, what we did was we took your list and we have ordered the list of information in a way that we thought was logical and built the story around your very cogent questions that we needed to provide for you that helps motivate all of us in moving to an understanding about our actions to secure the best possible care. So joining me today, as I mentioned, I have Ryan Erickson, who is the Director of Strategy and my incredible technical support, among other things. I also have joining me my Deputy Director, Dr. Lou Serbo. Also with me is my Chief Financial Officer, Jennifer White, my Chief Medical Officer, Dr. Brian Daly. So this is the team that's here for you to answer questions and to raise issues with you. And I'm just going to quickly go through again, Mr. Chairman, the items that you had asked us to talk about. So Ryan, why don't we go, here are the data requests. This is the order that the chairman asked me, but we put them in a different order, as you can see, because we thought logically it made sense for us to move through the data request to sort of build the story about what we know and what is the history and where we are today. So this will be obviously coming at you in terms of, there's just a few slides, and we'll go ahead, Ryan, and go to the next slide. So the chairman had asked us for a quick overview of Eleanor Slater Hospital. This is a long-term acute care hospital, and I want people to understand those words are important. It's a long-term acute care hospital. That means we're licensed as an LTAC, and we serve people with complex psychiatric and medical diagnoses, and in particular, we also provide services for people who have traumatic brain injuries, who are ventilator dependent, and who have intellectual and developmental disabilities. We are looking at this very long history of different hospitals that served different populations that were spread all over the state. And in 1994, the 4 separate facilities that were then in play came together, and we combined them to make the Eleanor Slater Hospital. So elements of LAD, elements of the Institute of Mental Health, elements of the General Hospital, and elements of Zambarano all came together and formed the Eleanor Slater Hospital. I think it's important to note that it has been known for decades as the hospital of last resort. And I think it's important to say that that in many ways has driven a lot of our experience, that the public population, the public, the healthcare industry sees this hospital as a hospital of last resort, because we basically were serving individuals who, under older models of care, were considered patients that could not be served in any other way in the community. We also want to reiterate that patients admitted to Eleanor Slater come through the forensic services. They are court mandated. I have no control on the flow. The court orders individuals for services, and we also have non-forensic admissions. And in fact, those non-forensic admissions are usually considered other psychiatric or other medical admissions, and they can't be served or couldn't be served in a nursing or community setting. Prior to 2020, we did not, I think, have what I would consider to be robust discharge protocols. That means that resulted in a long-term to end-of-life stays in the hospital. And as a benchmark, just for purposes of comparison, CMS guidance estimates that the typical length of stay for an LTAC hospital is between 30 to 90 days. Take a look at the chart that shows where people have stayed in our hospital. So from the Cranston campus for the Benton facility, the Adolf Meyer facility, and the Regan facility, and for the Burrillville campus at the Zambarano facility, you can see that the population is typified in terms of what kind of patients we have, how many patients are currently there as of today, and the average length of stay in those facilities. It's quite distinct. Next slide. The chairman also asked us about the role that the American with Disabilities Act and the Olmstead decision influences or should influence or may influence the running of the hospital and the future footprint of the hospital. Everyone knows that the Supreme Court held in the Olmstead decision that people with disabilities have a right to state-funded supports and services in the community rather than in institutions. And the Olmstead decision interprets the ADA so that the integration mandate basically requires public entities to administer services, programs, and activities in the most integrated setting, appropriate to the needs of the individual. The Olmstead decision actually centered on patients in psychiatric hospitals, but basically the later cases confirm that Olmstead applies to all state and Medicaid-funded institutions. Regulations implementing the Supreme Court's Olmstead decision continue to emphasize the development of community-based alternatives. And in fact, this reiterates what we have been saying for a long time, that once a person no longer needs hospital level of care, the state has an obligation to work with the person and their support team to discharge to the least restricted setting that meets their needs. Next slide. The chairman also asked about our current discharge process, and as I mentioned earlier, we really needed to look very closely at our discharge process because we were considered the hospital of last resort, that we were not applying what I considered to be a very sophisticated level of discharge review. And frankly, that came about because we were asked to go back and look at all of our patients and say, well, who are the patients that we're serving? When we went through the discussion about the IMD mix when I came on board in January of 2020. So we were looking at what the IMD mix was, and that triggered the conversation, well, then what do our patients look like? What is their original diagnosis? What brought them into the hospital? And when was the last time that they had been re-diagnosed? Because what brought them into the hospital may not be what had kept them there. So there wasn't a routine process for assessing the level of care and discharging people on a regular basis. So that's how the average length of stay grew to be 12 years. And every hospital in America, I hope around the world, is supposed to be doing discharge planning from the moment of admission. And we were not doing that. So we started to do what was appropriate hospital protocol. We began assessing level of care and meeting with patients to begin discharge planning. And the level of care is made by a clinician and a utilization review physician or a utilization review nurse. And so they needed to go back and look at everyone's original diagnosis, look at a more recent diagnosis and see if it was necessary, and then determine the level of care. So I'm clearly reiterating that it is our practice now and in the future to only discharge people who are willing to be discharged and who have a safe discharge plan. We are currently continuously trying to revise the policy to make sure that this is more clearly understood by the patients themselves, by the families, by the staff. We continue to meet with the advocates who support the work that we do with our patients in the hospital. And we've continued throughout the year in 2020 to be very public about our discharge policy and to make sure that if patients and family members disagreed with the discharge decisions, that there was a process that we would either say, let's think about this a little bit more. We'll come back and revisit the discharge planning process later when people feel more comfortable. Would you like to have a visit to an assisted living facility to see what it looks like? And that there's a process that people have in order to be able to appeal what has been a discharge review decision. And the next slide. We've also been asked by the chairman to look at who have we discharged recently. So since July 2020, the hospital has discharged approximately 22 non-forensic patients to home and community-based placements. So our discharge patients are constantly moving. They're generally in and out. They come in through the court order, they leave with a court order. And those are moving constantly. The non-forensic patients, this is the picture. Of those 22 patients, 2 went to a home, to their home or their family home. 14 went to mental health psychiatric rehabilitation residences, 1 to a nursing home, 2 to assisted living, and 1 to a developmental disability group home. Absolutely none of these 22 patients was discharged against their will. And in fact, that has been what we've tried very desperately to explain to people. But it is oftentimes the misconceptions and misinformation that has been out there in the public that people have chosen to believe rather than to believe the fact that everyone agreed to these discharges. In addition to the 22 discharges, there were 4 from Zambarano and 18 from Cranston. There have been 14 patient mortalities and 1 death resulted from COVID. So that's what the discharge has looked like since July. The next slide. The chairman also asked us to take a look at what we were doing about addressing the behavioral health continuum of care. This is the most essential issue for this entire discussion, as far as I'm concerned. The reality is that we know there is a gap that exists between the current continuum of care that prevents patients from transitioning into a less restrictive setting. The fact that there isn't enough movement across our healthcare system is a problem. There should be far more movement across different settings in our system. And we have been working very closely with EOHS and with Medicaid to look at that continuum of care to support people in the most appropriate environment. We've been working with trying to look at how to build some capacity within nursing facilities so that they feel confident and capable of dealing with these more complex patients. We've also tried to look at working with Medicaid on enhancing nursing home rates for people with high psychiatric needs so that they can obtain the behavioral health and psychiatric support they need. And we also are having conversations with multiple stakeholders under EOHHS, under the work that they're doing with the Faulkner Group, a whole series of stakeholder meetings to develop community-based options to look across the behavioral health continuum of care. We need to make sure that we can address anyone's interest in living in a community environment and enhance the capacity of all of these different community settings to serve individuals with high acuity behavioral health needs. We don't have that capacity yet. And therein is the dilemma. Therein is why I think the advocates are so concerned about this, is that we can't discharge many of these people in the hospital unless we have appropriate community settings. My one hope over time is that we will look at the American Rescue Plan and utilize the opportunity to help strengthen the behavioral health continuum of care so that in fact we can build the capacity and build the capability within community settings for people to be able to live when they choose to live in a lesser restricted environment. Next slide. The chairman also asked us to just identify that we have several high-profile patients. There's a very small number of patients with a history of high-profile criminal offenses who have been in the hospital. Basically, they have completed their sentences, their criminal justice sentences, and they were admitted to Eleanor Slater on a voluntary basis. There's no legal obligation for these patients to remain at Eleanor Slater, and they have served their time, and they don't meet any eligibility criteria for an involuntary commitment. They do not currently need a hospital level of service, nor do they need a hospital level of care. But given that these patients are at the hospital voluntarily, we continue to support them, we continue to serve them, and we continue to do continuous risk and safety assessments on each of these patients to ensure their own safety and to ensure the safety of other people in the hospital and to ensure the safety of the community environment if in fact they were ever discharged. Next slide. So the redesign and the transition proposal was conducted by Alvarez and Marcel. They delivered a report to us on the potential redesign, and they talked about the potential respective infrastructure changes that were necessary, and they delivered that report to us, and we, in turn, delivered that report to the governor, and in turn, we delivered the report to the House and Senate Finance Committees with the prioritization that the former governor had placed on the proposal. There were three scenarios that Alvarez and Marcel described. The first scenario was close Zambarano, close Regan, close Adolf Meyer, license Benton as an independent forensic hospital, develop capacity in the community for high acuity patients to be served in the least restricted environment. So basically that proposal from the consultants was close everything, keep Benton because you had to provide those services, and build the capacity within the community to take everyone. The second scenario was close Regan, close Adolf Meyer, license Benton as an independent forensic hospital, redefine Zambarano as a mixed-use, long-term care facility for populations that the existing continuum of care does not serve. That particular scenario was the one that the former governor approved and asked us to then speak to that proposal in House Finance and Senate Finance, which is what we did in October. And the third scenario was don't do anything, basically. In other words, get out of the Adolf Meyer building, which we needed to get out of for, we hope, in terms of some patient safety issues and for JACO, but maintain the Regan facility, maintain Benton, and maintain Zambarano under the existing licensure. So those proposals were basically what came to us from the consultants. And that regardless of whichever proposal was to be pursued, in this case, the former governor chose scenario 2, the hospital needed to engage in active discharge planning because no matter what, we had to provide evidence that we were allowing individuals the opportunity to transition to the most appropriate, least restrictive environment according to federal law. Next slide. So these are just some success stories. We are very proud of the discharges that we've made. We are particularly happy that we've worked so closely with some of the patients and with some of their families. I won't necessarily read each of these because they're there for you to take a look at. But in many cases, it's really a question of people beginning to understand that they didn't have to stay in the hospital for the rest of their life. That there was an opportunity if someone came to them and said, have you ever considered going to live in a nursing home that would be close to your family? And having those conversations has really been the joyful part of what we're doing in terms of making sure that people have a say in where they live and that they don't feel like they have to stay where they are unless there's a reason that their level of care deserves to stay in the hospital or they feel very strongly about staying in the hospital. But these 4 examples out of the 22, I think, are excellent and are really worth reading. Next slide. And then these last 2 slides are just Ryan, let's just do real quickly, go through them. This is some of the data, Mr. Chairman, that you asked us for, some admissions and aggregate discharges and discharge data by years, looking at 19, 20, and now 21. Looking at the overall census, which as you can see, other than 2016, and has been slightly coming down, but is holding fairly steady at the moment. And again, one of the reasons for the steadiness is because of COVID. So we're coming off of a year of COVID when there was not a lot of movement and not a lot of either leaving the hospital or coming into the hospital. Nursing homes were not moving people. We were not moving people. So the COVID year has really stalled a lot of movement, but that's, I think, where we are now as we're trying to understand where we might go further. And I think there's one more slide, Ryan. The chairman asked us about how we handled COVID at Eleanor Slater. During the latter part of the year in 2020, we had a surge of COVID-19 cases among both our staff and our patients at both campuses. We created COVID units both at Zambarano and at Regan. And we have tremendously been lucky that we were, of course, one of the first hospitals, one of the hospitals in Rhode Island to administer vaccines very early for the patients and the staff, many of whom have been willing to do so. But the COVID-19, as I said, has slowed discharges. And clearly we continue to, by the way, we test every week. We test for COVID every week in both hospital campuses. So we are continuing, despite the fact that most of our patients have been vaccinated, some of our staff have been vaccinated, and we are continuing to do tests across both campuses every week. And then because actually, not only because of COVID, but also frankly because of some of the publicity, we've had nursing homes basically say that they don't want to take our patients. So we think that there's going to be implications over time in terms of the way COVID affected us, but I think that's true for every institution. And I think then there's one more slide or one or two. So the chairman also asked about the Joint Commission. We are accredited by the Joint Commission, which is JCO, the Joint Commission for the Accreditation of Hospital Organizations. And we were last accredited in September of 2017. And there was a range of findings at that point, mostly looking at physical. There weren't issues related to patient care. There were really issues about building requirements and safety requirements for serving psychiatric patients. And we basically have been cited for ligature risk, which means that the environment is a place where people may think about harming themselves or could complete suicide because of the physical structures. And so we remediated that for JCO through 5-minute staff checks. So we have to still do 5-minute staff checks in those buildings. And that we knew that coming out of, and again, this was before my time coming back, but we knew from the JCO report that we needed to do some significant capital funding, which we needed to commit to remediate many of the physical deficiencies. We were given a preliminary notice of denial for accreditation, and we had 60 days to remediate findings. And then because of those findings and the remediation plan, the Joint Commission accredited the hospital retroactive to February 2017. And they were scheduled to return, because they come every 3 years, they were scheduled to return in September of 2020. But because of COVID, they haven't conducted any accreditation. But we're anticipating that they will come back imminently. We have a sense that they will arrive on our doorstep quite soon. And I think, Ryan, is that the last one, I think? And this is just the note about physical conditions of the building. Again, the discharges are patient-driven and client-driven, but we are in buildings that really have not been taken care of for a while. So the Adolf Meyer building is 80-plus years old. The Regan building is 45 years, and the Zambarano Beasley building is over 70 years old. And so we have aging structures that both EMG engineering as well as DCAM have come in periodically and looked at the buildings and done an assessment about what the current replacement value might be and how they would judge the buildings in terms of their current physical condition. So, Ryan, I think, is that it? Is that the end? Okay. Mr. Chairman, that's it. Thank you so much. I appreciate it. And we stand ready to answer your questions and to get your guidance about our next steps.
Director, thank you very much. Thank you for answering, I believe, all of those. I was going through each of the questions I had asked, and I believe you answered all of them, and then some. I know there are several questions the committee will have. We'll talk about that in a second. There's not a page number on here, but Director, I had written a note prior to coming to tonight's hearing that basically talked about the gaps in the behavioral health care system. And I concur with you, and I'm sure others on this phone as well, who've been looking at this even longer than I have, that the chart that talks about addressing the behavioral health continuum of care is the most important chart in this package, amongst other things. But moving forward from here, as we look to discharge folks and move them from whether it's Adolf Meyer, Regan, Zambarano, not so much Benton necessarily, maybe Benton as well, and going back to and I went back and looked at it again as it relates to the Olmsted decision. It's about the right services. It's about choice, that the individual wants to do that. And the third piece, which is probably most critical, and you articulated that as well, community-based services can reasonably be accommodated for that individual.
Right.
So I think some of the challenges we have in our continuum of care system isn't there. So potentially that might be where some of the challenges manifest themselves, where the questions might arise. One question I do have, Director, and then I'm going to go around and I'll ask. So committee members, I'd ask you to be thinking about your questions. We're going to do it a round robin fashion. Whoever wants to go first will go first, and then we'll go one at a time. And not that we'll stay here as long as we have to, but we want to be respectful of the 20 folks that we will be calling who want to verbally testify. So, Director, we talk about, and I always look at things from the perspective of, and I say it this way: what worked well, what didn't work well, and what do we need to change? So we talk about the discharge success stories. I can make an assumption they were all successful. I'll make this assumption for right now. They weren't all successful. I don't have facts or data to substantiate that. So the question was, do we have some that were not successful?
Of the 22 that were discharged, no, they were all successful. We do have some conversations going on with several patients who, one, do not have an interest in being discharged. Two, their family members do not want them to be discharged. We have several patients that don't have guardians, and so we're working out, trying to develop a stronger guardianship program so that those patients will have a guardian, and we're working with EOHHS to work on that. So there are many patients that we've had conversations with that are not ready, frankly, to either have a further conversation or are still quite hesitant about having a conversation about discharge. But of the 22 that we discharge, I think they were all successful.
Okay, thank you. I have other questions, but I want to go around and be respectful of members of the committee. I'm going to follow the same rule that I expect them to follow, the committee members to follow. Members of the committee with questions. Senator Dela Cruz.
I don't mind going first.
And Senator, if I can ask, we'll ask one. Go ahead, sorry.
What's that?
Let's go one question and we'll go around until we're done. Thank you.
Sounds good. I printed out, this is only about half of the testimony submitted to committee. I haven't finished getting it because it was about 3:30 when I received this packet. So I'll be going through all of it, but I was able to get some information from it. So I'd like to start off by saying no one wants to keep people institutionalized. I think we all agree that least restrictive setting is the best setting for individuals if it's safe for them and those around them. So my question is, in the proposal that Alvarez and Marcel, they stated Zambarano remains a specialized provider to fill in the gaps in the continuum of care and suggests several types of licensure that Zambarano would need in order to obtain in order to fill these gaps. Is that correct?
Yes, in one of the pictures, as I recall, in the Alvarez and Marcel, they talk about what kind of licensure would be needed in order to develop Zambarano as that facility that could treat those people that we didn't think would have a space in the community.
So of all of those licensures that for Zambarano proposed by Alvarez and Marcel, how many have you applied for?
We have started the work to do first of all, we've started the work to have a conversation with the Department of Health about a separate licensure for the Benton facility. And we have an ongoing conversation with the Department of Health about what it would take for us to get a license for a skilled nursing facility and a custodial level care facility. So we have opened those conversations with the Rhode Island Department of Health to do that.
So it sounds like one you've applied for or starting to apply for.
No, there's actually 3 we're looking at, but we have the application process is what we're learning, and the consultant is still helping us to figure out what exactly we have to have in place to do that.
Thank you, Director. Senator Gallo?
Thank you, Chairman, and thank you, Director Power. It's very nice to see a director actually answering the questions that were asked. I have to definitely compliment you on that. Many times, the questions are not answered. So it was quite comprehensive. I disagree respectfully with you about a hospital of last resort. I've had many constituents and not constituents tell us about the wonderful care that they get at the hospitals and how they want to be there and how compassionate the staff is and how wonderful it is. And I think maybe that's why a lot of people aren't willing to leave, is because of the wonderful staff that you have employed through the years, and how the patients don't get back sores, don't get sore, the sores and everything that a lot of people do. I question the consultant firm's motivation for what they have said of what is recommended and not recommended, and what their motivation is, without getting into that. And I don't want to be aggressive with that. I just want to say that I want to be on record saying that the consulting firms perhaps have motivation to report the way that they're reporting. And I don't see them as being disinterested in any manner at all. I have to disagree with that. I do not support the closing of all of these buildings. I do not support, I want to be on record saying that I think that we provide wonderful care. And I actually had a meeting recently with some interested parties, and I brought up the point of when my mother was in the hospital and she had Alzheimer's, and she, couldn't exactly do everything that they expected of her. And in the hospital, they had said that she was going to have to leave because she wasn't making any progress, and she needed to make so much progress in order to be discharged. And when I went with her and I said, Ma, you got to work as hard as you can so that, you can get the treatment that you need. Well, and behold, within that day, she made so much progress that she was going to be discharged. So I know that medically it's expensive to keep people in facilities that are expensive. However, I think we need to look at the patients, at their caregivers, at their family, and question if we want those decisions to be made in the same manner as what I'm saying happened in the hospital. I know they're trying to keep the cost off. Either you're not doing enough or you're doing enough. You're going to go no matter what. So all of these people being discharged within the last, whatever, maybe a half a year or whatever, I question how they're made, who's making them, and I would hope that we would have some passion for these people, because what we're doing to our neighbors could be done to us. And I would ask you to please look at what we're doing and how we're doing it. Thank you.
Thank you, Senator. And I take your comments to heart. I think that, one, I want to acknowledge the fact that we do deliver extraordinary care. And I think the relationship that is built between the staff at the hospital and the patients we serve is quite amazing, quite extraordinary, and really special. I think one of the issues for us is that the 22 discharges is really not unusual for us in terms of the normal pace of things relative to movement of people. And I think that what I've noticed, and I'll make just this observation, what I've noticed is that culturally and socially, we have families that are not sending their family member to the hospitals anymore. They're keeping them at home longer, or they're keeping them in assisted living, or they're sending them to hospice, or they're doing whatever would keep them closer to home. And so therefore I've watched that, over the last several years, that people are simply not sending people to the hospital. And when I say it's the hospital of last resort, I don't mean that negatively. I mean, that frankly, positively, in the sense that people valued the care that was there, but that proportionately and culturally, they're not sending as many people, or we're seeing families keeping people closer to them at home rather than sending them into the hospital for a long period of time. That's just been, I think, what I've noticed. So thank you for your comments. I appreciate it.
Thank you.
Thank you, Senator. Thank you, Director. Senator Archibald?
Thank you, Mr. Chairman. Dr. Power, thank you for your very detailed analysis on the history of Zambarano and where we've come to today. My question, and I'm not entirely certain you can answer it because you're new to the task of guiding things, but seeing how competent you are and inferring that you really understand this in great detail, perhaps more than any of us here, I'm troubled by the fact that prior to 2020, there wasn't any level of care discharge plan in place. Can you help us to understand why that was the case? I'm not looking to point fingers. I'm just trying to get an understanding on the whole ideology of why that didn't exist before 2020, and why now we've come into the right focus.
Well, I think what I understand, and again, I'm not sure I can answer it, because the hospital was seen as the place where patients who were very complex and could not be treated any other community environment, that the thinking on everyone's part was that they came into the hospital, they stayed there for a time, they were treated based on the diagnosis that brought them into the hospital. After a certain period of time, there should be a normal process of re-diagnosis. That was really the issue that I discovered, is that we had individuals who came into the hospital years and years and years ago, but nobody had ever looked at re-diagnosing them. And so I think it was because it was a hospital where people generally believed that they would go and stay there for a long period of time and perhaps die there because they were so complicated that they couldn't be taken care of elsewhere, that somehow contributed to the fact that people were not aggressively trying to figure out what would be the next step, what would be a step-down service, what would be a less restricted environment. And again, as I say, the LTAC license was really originally designed to take on patients who came out of acute hospitals, who had a little bit greater need for a particular support, wound management, ventilator dependency. And what happened as we closed some of the institutions, that the specific skill to take care of someone with a serious mental illness, someone with a developmental disability, was not growing in the community. And that's that continuum of care that I think we lost track of. We neglected, I guess is what I'm saying. The state neglected to continue to develop those opportunities. So therefore, that really contributed to people not being discharged and not being looked at and not having an aggressive discharge process. And again, I'm speculating about that, Senator, so.
Well, if I may, Mr. Chair, may I follow up?
Yes.
Yeah, thank you, Doctor. So maybe then a little more light here, if you could, about the juxtaposition between how we didn't do that in the past and how we're doing it now. We're on this bold, healthy path. How is it that things changed? How is it that things changed from decades of not having these level of care discharge plans, and now we have them? I mean, my question maybe even has some rhetorical root to it, but I just want you to amplify on it. I want to understand it better. Thanks.
Well, I think that once we started to ask the question about where would patients most likely, where should patients be based on the level of care that they need? And once we did the analysis of all the current patients, we discovered that they were, frankly, receiving a nursing home level of care. That was basically what we discovered. So either custodial care or a nursing home level of care was what they were provided, or what we were providing them. And so we began to ask the question, all right, are there any opportunities out in the community that, that is a place where these individuals might go? And so we started to have conversations. And we know that starting in 2019, we began to understand that hospitals were changing themselves, and we were not necessarily keeping up with the kind of transition that needed to go on across the healthcare system. So I think that for me, it's trying to understand that the level of care that we were delivering, exceptional as it is, exceptional as it was not a hospital level of care. And therefore, we couldn't continue to provide the level of care in the hospital as a bona fide service. We had to cultivate nursing homes, assisted living environments, and we're not there yet, Senator. I mean, we haven't got anywhere near the capacity in the community service systems to treat these people. We are going to have to continue to treat them until we can develop that community of care.
Thank you, Director.
Thank you very much, Doctor. Thank you. That helped. Thank you.
Other senators before we go around again. Senator Seveny, then Senator Acosta. Senator Seveny?
Yeah, I'm just trying to unmute
Okay.
myself here.
There you go.
So, Doctor, you mentioned early on in your pitch, your concern with the federal rules regarding thresholds of how many people, the hospital can deal with for mental illness type conditions. And I think I heard what you suggested is that these rules are flawed and they need to be fixed. So my question is somebody reaching out to our congressional delegation to try to do that? Because it seems to me that, well, we're not going to get into the budgetary aspects of Eleanor Slater and all that. Everybody's under pressure because of the Medicaid circumstance.
Right.
And are we getting our congressional delegation to help fix this rule if it's broken so that we can do what we need to do? Deal with the circumstances that are
Right.
you're making. I mean, I would be the last person that wants you to do something with a patient when you know there really isn't anywhere in the system for that patient to go, even though they should. That's fine, but they got to have a place to land too. So, what are you doing to engage, our delegation to go help fix this? We're on mute.
I didn't realize, sorry. Somebody out there muted me. I think that, yes, we've been very clear with the congressional delegation. I have been very clear as both a state person and when I was a federal agent, that this discriminatory rule is terrible. It has existed since 1965, when Medicaid became law, and everyone has vociferously opposed it. When you're in my position, if you're a state mental health authority or you run a hospital, we have vocally opposed this IMD exclusion for years, and the congressional delegation knows that. There was a ray of hope when the prior administration came in and they put the IMD exclusion on a list of the things they wanted to accomplish to get rid of in the last administration. I'm hoping we can pull out that list and put it again in front of this new administration in Washington and reignite our congressional delegation to do something about it, because I think it's what it does, Senator. It's a restraint and it's a discrimination for people to get care, but it also is an incredible restraint on spending. And I think that's the balance. And I I think it should be lifted, and I've advocated for such a discriminatory rule to be changed and obliterated for a long time. So we will reignite our congressional delegation with the new administration in Washington, and maybe we can get some change.
Just before we go to Senator Acosta, Director, if I can just follow up on that. I appreciate the sentiment to try and get that to change. I guess the challenge would be if I go back and I spend a lot of time speaking with one of your other directors on the DD world as it relates to the Olmstead decision or whatever. Was that put in, I know the Olmstead came later than that, but if we think about the exclusion there, is the real push of not putting it back in the impetus for that to ensure individuals, for whatever treatment they need, whatever services they need, they are going back to the criteria we talked about before. They're getting the right services, they have a choice, and the community can provide those services and reasonably accommodate that.
Right.
Because I almost look at it from the perspective of, yes, they can be in a acute care facility or hospital in general, but is that really where we want the individual to be? Because it's potentially not the most restrictive, it's not the least restrictive setting that in which that individual can operate.
No, I think you point out a very good paradox. In other words, we still want to build, and we need to stay focused on building a community capacity so people have the choice of where they want to provide or where they want to obtain their services. I think it's just a long-standing discriminatory action that in and of itself has contributed to the discrimination against people with mental illnesses, which we no longer have, thanks to your leadership and others, for individuals with intellectual and developmental disabilities, because they opened up Medicaid for them, and in fact, they have multiple choices protected. So one of the difficulties is, I don't necessarily want to get rid of the IMD exclusion just so I can open the floodgates to send people into a hospital.
Right.
It's a statement that basically says we've contributed to the discrimination of people with mental illnesses because of this kind of exclusion, rather than saying I want to open up the door and spend more money in every psychiatric hospital.
Thank you, Director. Well said. Senator Acosta.
Thank you, Mr. Chairman, and thank you, Director, for your presentation and overview on an issue that I'm frankly not very familiar with. I'd like to ask you to be a bit more blunt about this question of consensual discharge versus disputed discharge. So we received materials today making accusations about disputed discharges, making demands that we place a moratorium on disputed discharges. And, you know, I thought I was clear as you described your consensual discharge process, and then you said something to the effect of, if patients and family disagreed, then we ... And that to me sounds like a process of cultivating consent, which I can understand. And so what I'm trying to figure out now is, are the claims about disputed discharge the result of some kind of breakdown in cultivating consent, where people feel pressured by the institution to push their family members out? Is this from an aggrieved labor union that fears jobs that are going to be cut, and so is just lobbing these attacks and claims at the institution? Where is this coming from, I guess, is what I'm asking.
Well, I'm not quite sure which part you want me to be blunt about, but I think that what we've tried to do is move forward with a more descriptive discharge process as we've learned how to do it. I mean, frankly, we all had to begin from the scratch, saying, all right, since we're not doing discharges as people are admitted, that's when we have to start doing discharges. What is the discharge process we are going to do as people come into the hospital? So we've started that process. The second process is for people that are already in the hospital. We had to lay out, and it's been a very long and noisy and painful process to do that, because the families are telling us what they want, the patients are telling us what they want, the advocates are telling us what they want, the staff are telling us what they want. So we've tried to put together as clear a process as we can and it's still evolving. We still need to do some work on it in terms of defining very clearly what the dispute process is. And EOHHS is helping inform us with that by helping us learn if there's a Medicaid dispute, how do you handle that? If there's a Medicare dispute, how do you handle that? So we're trying to learn from the folks who know how to deal with dispute on discharges, and we're putting together a process that we think will be fair. And then we're also ensuring that there will be outside review, not just our own physicians and our own nurses and our own social workers, but if there's a dispute, that we will have an outside review, then determine appropriate level of care and whether or not the discharge policy is appropriate. And at that point, if people still believe strongly that they do not want to leave the hospital, they won't leave. I will not discharge them.
Thank you, Director. Other questions from other committee members who haven't asked a question yet? Senator Dela Cruz, back to you.
Thank you, Chairman. The Senator Archambault brought up the point, he had asked the question about the discharges and how often the conversation is had. And it sounded like the answer from the administration was it had not happened recently until they implemented this process. But I want to make sure that that's what I understood, because the discharge process has been in place, I believe, and is discussed every 3 months with patients and has been for many, many years. So is that the case where every 3 months there is that conversation?
I'm not sure. I'm going to ask Dr. Daly to make sure that I'm correct about this. My understanding is that there was a discharge process that was going on prior to us starting this more robust discharge process, that there were conversations going on all the time about discharge, particularly around the forensic patients and particularly around those patients that we felt could be moved appropriately, but that they weren't occurring across the board all the time, and they were not occurring as frequently as they are now. So, Senator, that's my understanding, but I'm going to defer to Dr. Daly.
Thank you, Director. Hi, Mr. Chairman. Hi, Senator Dela Cruz. Good to see you again. So, I think I can shed a little bit of light on this. You're referring to, I think, the treatment care planning conferences, which occur every 90 days. And in those conferences, they'll talk about a great many things. Those are the ones where a patient is brought in and or family members and or guardians. So for those patients who are approaching discharge, they will discuss discharge. But the problem is, for many of our long-term patients, they weren't really discussing discharge. They were just discussing treatment. So that would be the place where that would be done. Before 2020, we did have a pretty robust discharge planning process for forensic patients, but the rest of the hospital was not so much, as the director has said before. So I think it depended on the specific patient. Obviously, if somebody was approaching a time of discharge, they would be doing it in those conferences that you mentioned. But for many of them, there would be years, quite frankly, where that wasn't discussed, right? If they were here for 12, 13, 14, 15 years, most of that time, there wouldn't be a lot of discussion about discharge. Does that answer your question?
Yes, it does.
Thank you, Dr. Daly.
Thank you. Thank you.
Director, one question I had, then we'll go, I'm still going to give a summary comment in a minute before we go back to questions. We mentioned earlier in your testimony with regards to patient medical records. And I can recall Congressman Patrick Kennedy, who hasn't been a congressman since 2010. And I think his dad, deceased, Senator Ted Kennedy, I think he was pushing that as well. And I'm sure you'll be more familiar with this than I, as it relates to electronic patient records back a decade ago. Regardless of what happens, or whatever moves forward with whatever situation, is there an effort underway to immediately transition to electronic patient records across the system?
We have put in this year in our budget funds for the for obtaining an electronic medical record, which really includes sort of an automated patient record system that would be started once somebody comes in at admission, that includes individual data about the patient and then starts the discharge planning process. So a whole electronic medical record, we have put that in the budget, Senator, this year. And as far as I know, it is still in the budget, and we're hoping to obtain it. From what I understand, the department and the hospital has asked for support for an electronic medical record for at least the last 20 years. And I'm hoping that this year it survives in the budget.
Oh, thank you. I guess, let me just make a comment, I guess, with regards to a general comment on the investment in Rhode Islanders and people. I wasn't going to, but since you mentioned that, and that's been asked for, so I'll take responsibility as subcommittee chair for EOHHS for not knowing that, number one. Number two, not doing anything about it. So we'll see where that goes this year. But
Thank you.
when we look at the end of the day, the Pastore complex and the Eleanor Slater complex, and I'm going to mention several different facilities in no particular order, just how I remember them, whatever. So we have a traffic tribunal, a DMV, training school, where Benton is. We have new AG's office there. We've completely revamped VERX. And I don't know, I forgot which building, you or the secretary would know which building the Department of Labor and Training is in. I don't remember what building that is. All of those, each one of those has had extensive upgrades or brand new buildings in the last N number of years. I don't know when the traffic tribunal was built or the DMV, AG's office was just recently done, VERX and the other one a short time ago, and the Benton facility at the training school was a little time after that. You notice I didn't say Regan, I didn't say Adolf Meyer, I didn't say Zambarano. While we've done some work there, the places where people live, the places where patients live, on these two campuses have had little to no investment over any extended period of time. I'm not going to say none because I know that answer is wrong. I don't know the number. We've addressed some of those things, I think, because of a ligature issue after 2017, maybe some before that. And we've not even invested, please don't take any of this directly. Like I said, I'm going to take it back to myself. We've invested almost nothing where people live on those two campuses, in Burrillville and Cranston. But we've done some of the peripheral ones where people visit. Just a statement, I'm not going to ask you to comment. We need to change that and change that post haste. So what I'd like to be able to do, I know several of us have more questions. Unless somebody has a burning question, I'd like to be able to move on to the probably 20 or so. Before we do that, Senator Gallo, we're going to go to Senator Gallo.
Thank you. Just one more question. I was just wondering, as far as Alliance is concerned with doing the discharge planning, how are they the state's ombudsman and they're doing that discharge planning for the state too? Like, how's that happening? Mm-hmm. And I don't know who wants to answer that.
We're having very robust conversations with the ombudsman and with the advocates, and they have actually been informing us along the way about areas where we could improve the discharge process. They're continuing to do that. We have animated conversations with them on a regular basis, and they've been extraordinarily helpful to us. And the long-term care ombudsman and the mental health advocate and many of the others have not been bashful at all about sharing their ideas about what we should be doing better and how we should be engaging people in a more thoughtful way. And we've taken those critiques very seriously. So we're engaged with them on a regular basis.
Thank you. It was concerning to me, so thank you that you are looking into that. Thank you. And I apologize for two questions there. Thank you.
Senator, not a problem. Good. Thank you for raising it up. Senator Miller.
First of all, I want to
thank Senator DiPalma for letting Health and Human Services have those who were interested join in this discussion. It's not groundbreaking. We've done this often in having joint hearings with the Finance Committee, crossover on our concerns and interests. I just want to go over a little bit on history and what I see as issues that history may have taught us. We talk about the IMD exclusion, and I think it might be an analogy to say that it could also be the one flew over the cuckoo's nest exclusion, in that there was a history throughout America that the IMD was intended to fix by having hospitalization not be the only setting for behavioral health situations. And therefore the IMD in 1965. And the problem that I'd like to get to that brought up was that we now even have the situation currently where, because they went quickly to the IMD exclusion with the intent of getting rid of hospitalization or minimizing hospitalization to when it was appropriate, is that there was a surge, and we still have the impact of those who should be under behavioral health care are often incarcerated or homeless or in other situations that are absolutely inappropriate. And so my question, if it is a question, and I think you've already talked about it, which I'm really grateful you have, is discharging to a continuum of care and having the capacity in the community. And does Rhode Island have that capacity currently? And should the cart come before the horse so we don't make the same mistake? And having, when we consider what we do to improve Slater, do we do enough consideration on what we do to improve the amount of community care that's present in Rhode Island, so we don't add to what we see with the evolution of 1965 to currently, of having people in totally inappropriate settings, whether it be homeless, no care, incarcerated when they should be in a different setting. And I know we have we have a great confluence of history right now where we're on the verge of CARA 3.0, that the America Rescue Plan was passed. There's additional SAMHSA funding. Even an infrastructure bill on the federal level could help fill some of these gaps. But the thing that I see most probably quickly remedied, at least in Rhode Island, is an understanding of what kind of reimbursement needs to be reformed on the Medicaid side in order to encourage the continuum of care and those kind of providers being in the community, because right now the incentive with the low Medicaid reimbursement rates is almost not to provide these services because the reimbursement is inadequate.
Senator, I think you have such a grounded history and knowledge about this that I can only comment that your observations are extraordinarily valid, and we do not currently have the capacity that we need, and we do not currently have the capability that we need, and we need to do a number of things. We need to take a look at the behavioral health continuum of care scenario that's been laid out under EOHHS and Medicaid and the Faulkner Group, and they are laying out what we think we need to do, and that there's a couple of things. The first is that we should continue to be promoting the SAMHSA model of the comprehensive community behavioral health centers, which really pick up the thread of the original community mental health centers and give responsibility to those agencies to make sure that they are supporting people in the community. Secondarily, we need to reimburse them at a level that is appropriate and commensurate to the care. And we need to look across the rate the rates that have been set by the MCOs and see, and frankly, look at whether or not they are commensurate with what should be delivered in terms of evidence-based practices, quality of care, and improved outcomes. And those pieces are all, as you say, enormously important, and they're within our grasp. Frankly, they are within our grasp. If we can look at using opportunities that are coming in terms of additional resources, in terms of readiness on the part of the providers and the advocates, in terms of the individuals themselves who have these conditions, who want to move into appropriate places, we can expand certain pieces. We can expand MHPRRs, we can expand nursing homes and assisted living, we can expand substance abuse and recovery homes so that people have a much more stable environment in which to live. We can make sure there's appropriate housing for people with these conditions. All of that is what we can put together, and I think we've got the brain power to do it. I think we finally might have some resources to do it, but I think we have to attack it head on, look at the reimbursement rates, look at the capability and capacity of the providers so that they can expand their own vision, and that we can in fact turn to the community embracing the responsibility for keeping people stabilized in the community and making sure that they don't return into institutional care.
Right, and if I can add to that, if I can add to that, first of all, Senator Miller, it's great to see you this evening. It's been quite a while since we last encountered one another, and you know my positioning as it relates to, you know my position related to quite a bit, but definitely social determinants of health. And when you even look at social determinants of health, and you look at this topic as it relates to rates, the piece we have to build a system within Rhode Island that truly gives everyone to live in a setting of their choice that is appropriate based upon their needs, and ensuring that within community is safe, the individual is safe, and so on. And EOHHS stands ready to assist as it relates to putting forth the necessary work to have rates, whether it be in this space or, as Catherine is aware, the space of substance use disorder, but doing that to have a review to see where are we and where should we be. And all of this goes hand in hand, and EOHHS has been and continues to be and will be at the ready to help do this needed assessment. So that is something that EOHHS is definitely committed to, but also as it relates to being that umbrella agency, helping our departments be able to get to where they need to be to best serve the residents that we are charged with serving.
Thank you, Secretary. Thank you, Director. Senator Lombardo. Senator Lombardo, I think you're on mute, Senator. Senator Lombardo? Well, let's go to Senator De La Cruz, and we'll come back to Senator Lombardo.
Thank you, Mr. Chairman. I've heard a few times today, least restrictive setting, the Olmstead Act, and again, we all want that for individuals. I'd like to point out that the Olmstead Act doesn't just end there. It goes on to say that the court also upheld that public entities must provide community-based services to a person with disabilities when, 1, such services are appropriate, 2, affected persons do not oppose community-based treatment, and 3, community-based services can be reasonably accommodated, taking into account resources available to the public entity. I'd like to point out a couple of things before I ask my question. I have here, I think all of you have seen or at least have heard, that there have been 2 physicians quoted in the Providence Journal that they were pushed to discharge patients. The doctors accused the hospital administration of discharging patients with long-term physical and mental illnesses who, in reality, had nowhere adequate to go. We see one individual that set fire to her apartment building and displaced 60 people. There's another individual who ripped out a window from the frame of a home, and consequently the home was condemned. There was another individual I was just speaking to, they wanted to come back to the hospital, to Zambarano. They felt they made a decision that was not in the best interest for them and their families, and was not admitted re-entry, even though it was within a 30-day time period. Individual was sent to Rhode Island Hospital, then sent to Miriam Hospital. I thought it was Butler, but it's Miriam Hospital, then sent back to Rhode Island Hospital, where eventually they said, you can't stay any longer. So the individual is now residing in Massachusetts, and our tax dollars are going to pay for that individual, when that individual could very well be serviced here and his family much closer. So, with that, does the administration take issue with the public comments expressed by Dr. DeSellis and Dr. Paquette with regard to the current discharge acceleration and pressure? If so, how so?
Director, Senator, if I may, Dr. DeSales will be up to testify very soon. He's near the top of the list based on him signing up. So you want to hold that question for Dr. DeSales when he comes up?
No, I'd like to ask the administration if they take issue with
Okay.
with the public comments that those two physicians made, and if so, I'd like to know.
And Dr. Paquette also, by the way, is also on the list to testify, just as an FYI. Thank you.
So I'll start and say, yes, I take issue with both of those physicians' statements. And frankly, I'm rather disheartened by the fact that they were given the amount of press coverage that they were, and that they had their opinion, and I disagree with it. And furthermore, the conversations to be had about any of the patients is confidential information, and frankly, should not be discussed in terms of the public environment, because it is protected health information. And I will ask Dr. Daly if he wants to add anything as my chief medical officer. He has the relationships with all of the medical personnel. And I will also tell you that when I visited Zambarano in the summer, I had a chance to meet with all of the physicians who work there. And we had a candid conversation about the level of care that was being delivered to the patients at Zambarano. And all of the doctors agreed and shared with me that the level of care that was being delivered was nursing home level of care and not hospital level of care. So when I'm told that by the physicians who work there, I believe them. So therefore, I don't hold to what the two physicians have stated in that we were forcing them to do anything. Dr. Daly?
Thank you, Director. Yes, Senator, thank you for the question. So I can address that a little bit. We're a bit hamstrung, as the Director said, because we can't release HIPAA information, right? That means protected health information. But the numbers you're talking about are a little mixed and matched with the two campuses. So just to be clear, last year in calendar 2020, we discharged 4 patients from the Zambarano facility. Every single one of them was a patient that was discharged by the physician there. The physician would have signed the discharge order. All of them were patients who agreed to be discharged. All of the discharges that were mentioned are cases where people agreed to be discharged, or their guardians agreed if it was a situation where a person has a guardian. So that's a global comment, just because I'm precluded from discussing any specific case. You mentioned some specifics. Of course, I know they were in the paper, but still, I have information that's protected and can't really discuss them individually. Does that answer the question? Thank you.
Thank you, Doctor. Thank you, Director. Senator Lombardo, can you come off of mute? It would be on your end, Senator. We'll come back. I think we have one last question. Senator Archibald.
Thank you, Mr. Chairman. I'm going to ask a question that amplifies on what Senator Dela Cruz just asked. And I'll preface this by saying, look, I take most of the media and what's said in the paper with a grain of salt. Over the years, having been in various articles and having read them and said to myself, that's not what happened at all. I was there. That's just not true. So I take things with a grain of salt, but it is concerning when, more than one individual, docs actually, were pressured to move people out. That's what the article says. So my question then goes to, who's running Zambarano now? I mean, I know the answer, right? It's an individual named Jennifer White. And can you help me to understand what her qualifications are to be CEO of Zambarano?
Now, Jennifer is currently the chief financial officer. She is not running the hospital. We are running the hospital using the Joint Conference Committee, which is the JCO required group. That includes me as the governing body. That includes Dr. Serbo as the deputy in supporting me. That includes Dr. Daly as the chief medical officer. That includes the other chief nursing officer, Eileen Dobbin. That includes my chief quality officer, Nancy Fogarty. So there's a group called the Joint Conference Committee, and we are responsible for the operation and the running of Eleanor Slater Hospital. There is also a site administrator at Zambarano, which, by the way, I returned. The former leadership of the hospital had taken a site administrator away from Zambarano, and I restored a site administrator on the site to make sure that we had administrative leadership at Zambarano. So it's really a group, executive group team that's doing the overall responsibility for leading and operating the hospital at this point.
Well, let me just, Mr. Chairman, one follow-up, please. We can move on. I appreciate that, Doctor. Then can you tell me what authority or oversight or input the CFO has beyond simply the financial aspects of running Zambarano? Because I'm privy to a whole different conversation that and analysis that I don't want to get into too much detail here on. So can you help me understand if her duties are limited?
Well, the duties across the department as a CFO are pretty broad in terms of interpreting the budgetary needs across program and policy, in preparing the budget, in doing analysis of costs, and in tracking contracts, and in doing a whole variety of things. In this particular case, we have a CFO who came on board a few months before I came back on board in January, and she has some experience working in the for-profit hospital world and the not-for-profit hospital world. So she's been a terrific advisor, frankly, to me around the process of moving forward in terms of a modern healthcare hospital system. And she's frankly one of the few people that I have that has that experience, that has been involved in the private sector, the public sector, the not-for-profit sector, and the profit sector. And I'd be happy to share her resume with you. And she really became sort of an expert for me to be able to utilize in terms of hospital operations and understanding billing and understanding Medicare and understanding Medicaid and understanding third-party billing and understanding level of care in conjunction with my chief medical officer, my chief nursing officer, and my chief quality officer.
Thank you, Director. Thank you, Senator. We're going to move along. We have Senator De La Cruz has one final question, and I do have a question for Senator Lombardo that I would ask momentarily. Senator De La Cruz.
Thank you, Chairman, for allowing me to ask another question. There's been a lot of talk of that the administration is trying to close Zambarano Hospital, started with the Raimondo administration and possibly will continue with this administration. We're not sure. But there have been no new admissions to Zambarano Hospital since May of 2020, I'm told. Currently in 2021, still no new admissions, and physicians are being eliminated at the hospital, switchboard, a kitchen position, and I think there are some layoffs about to happen. And now currently for, I believe, 75 patients, there are 2 physicians that work Monday through Friday. There's no overnight coverage and there's no weekend coverage. And my tour on Wednesday of the facility, I spoke to one of the physicians that said, I asked her, I said, is that a sufficient number of physicians to care for the population? She said, when you're just looking at the sugar numbers and chart information, it's perfectly fine. However, if we're assessing the patient and modifying their treatment, it's not. We need more physicians. And I said, what happens if you call, if there's an emergency on the weekend and there's no physician on call? Well, there's Rhode Island Hospital an hour away. So if your plan, and I keep hearing that is not the plan to close Zambarano, if your plan for Zambarano is not closure, I'd also like to know why then on the Alvarez and Marcel report, it says eliminate under the October 31st, 2020, under that column labeled physician labor on page 16. If your proposal is not to close the facility, why are there no new admissions and people are being laid off?
I will start, Senator, with my understanding about how to best answer the questions, and then I may ask, again, Dr. Daly to step in since he's more familiar directly with some of the issues. First of all, the overarching picture of the hospital is that today we have 191 patients. And we have 704 staff. So we're looking at what is happening as we are reducing our census in some cases, slowly but surely reducing our census. And in some cases then adjusting staff and adjusting the staffing model to the number of patients that we have. I think we were overstaffed. That's just a statement I'm going to make. I think we're overstaffed at the hospital for a variety of levels. I think that we need to take a look every day, every week, every month on what are the patients that we're serving and what's the appropriate staffing level that we need to have to meet what are considered standard practice standards around the staffing level. We have in fact laid off, I think, 8 people up to this point out of 702. And we've tried to make those decisions based on the level of care, based on the current patient population, based on the current need. And so this is a fluid situation, and we're making those choices based on how quickly we move in and out of some of the buildings. All of that has stalled. So I'm stalled in terms of moving people. I'm stalled in terms of moving patients out of Adolf Meyer. I was going to move the vent patients to Zambarano. I'm stalled doing that. 1, because of COVID, and 2, because of some of the building restrictions. So in terms of where people are going, we continue to monitor who can go where. We cannot take any psych patients at Zambarano because we're restricted by JCO to put psych patients at the Zambarano campus because of the physical structures. And we're managing what we can manage. We're also trying to have more people go to a forensic outpatient service than go into Benton, so we can try to control the Benton facility census. And it's every day we're trying to do that. So it's a challenge. So Dr. Daly, do you want to add anything to that?
Doc, I was going to say, if we can just,
Sorry, Mr. Chairman.
I think we're good on the answer. I think if I can make a command decision here for a second. I don't get to do that often, but I'll do that for this minute. I want to ask one question for Senator Lombardo, if I may. He wasn't able to get off mute, and then I'll just wrap up this section and we'll go to the folks that are going to testify verbally. So Jamie, if we want to give them a heads up. So the question here, Director, is since we started to discharge patients, is there a common perception by the public and media that people with mental disorder are likely to be more dangerous and violent when released into the community? If so, how do we educate the public if that's true or not? If it's not true, how do we educate the public either way?
Well, I think it's a great question. And I think there are lingering perceptions about the issue of someone having a behavioral health condition that they may or may not be danger to not only to themselves, but also to others. Or those perceptions are often, I think, misguided. And generally, we often talk about the fact that individuals with mental illnesses are often victims of violence rather than the perpetrators of violence, which is another myth that we have to overcome every day. I think that we have continued to try to work hard to reduce the discrimination and fear and isolation that comes from some of the beliefs about individuals with substance use disorders or mental illnesses. But there's a long way to go. I am completely disheartened by the fact that people in America do not know that your chances of having a mental illness are 1 in 5 in your lifetime. Those are common conditions, common occurrences, and people do not perceive that commonality. And there's a lot of this distrust about people with these conditions as the other, and they need to be separated from us, rather than learning how to live with and control and self-manage their conditions, which they can do very successfully. And we have a lot of wonderful people who manage their conditions very successfully. But oftentimes it's only person to person or a family member or someone you know or a neighbor that teaches you that. It's not that a lot of the myths and the misconceptions about people with mental illnesses continue to survive. And it's very unfortunate.
Thank you, Director. I just want to summarize very briefly so we can get over to, we have 21, I counted incorrectly, folks that potentially will testify. And we'll summarize that before we get there. But Director, Secretary, Dr. Daly, et cetera, Deputy Secretary, I think you've heard obviously quite a bit of passion clearly from the folks who represent those districts, Senator Gallo, Senator Dela Cruz, from a Cranston and Burrowville area, but clearly the entire committee. There wasn't a committee member who didn't ask a question, and then some members beyond the Oversight Committee. This is a critical issue for the state of Rhode Island. It's a critical issue that, very respectfully direct, based on one of the questions I think Senator Archambault asked, has not been addressed and has not been addressed, Director, until you came onto the scene. So thank you for coming onto the scene. Thank you for bringing this forward. It is a critical issue that needs to be addressed. It's here now. We're going to address it. We will, whether we have another hearing on this, I know this been extensive. We're going to go longer, obviously, with regards to addressing the public comment here and see what other information that will come forward. But thank you for being with us for the time. Hopefully you can stay along, or somebody can stay in case some questions come up. But we do appreciate you having been here for, right now, exactly 2 hours since we started this. So thank you very much. I realize if you may have other commitments you may have to attend to, but the committee will be hearing from the folks who will verbally be testifying. I should also thank Ryan as well for his time in supporting this hearing. It's a critical issue that potentially impacts all of Rhode Islanders one way or the other, and we will address it. So thank you.
Thank you, Senator. Appreciate it. And thank you to the members of the committee for your incredible interest and caring and concern for the people we serve. So thank you very much.
Director, there is one thing while we're getting the first person on the phone. Let she go. She's gone. Oh, you're back. Thank you really quick. I will probably follow back with yourself and the secretary on the all popular Alvarez and Marcel report.
Okay.
Both the unabridged, and thank you for sending in the unabridged
Right.
complete report. I think we need to see how to make that available to the public. And
All right, sir.
We will talk to that. I know there's some challenges there. I think we can work through the challenges. It has valuable information in there, and we paid a lot of taxpayer dollars to do that. So thank you again.
Yes, sir.
Okay.
Okay, will do.
Thank you.
Looking forward to it. Thank you.
Are we good?
Thank you.
Thank you very much. I think we're going to move to our first person to testify on the phone. Stand by. There we go.
Hello?
Tina,
Yes.
thank you very much. If you could just introduce yourself and begin your testimony.
Thank you. Thank you, Chairman and members of the committee. My name is Tina Spears. I'm the Executive Director of the Community Provider Network of Rhode Island. I'll make my comments brief today. I would just like to first start by acknowledging all the testimony that we heard today from the administration and the candor and detail that was shared. I represent 30 community-based providers, 23 of whom are providers of services for adults with intellectual and developmental disabilities who live within the community. The individuals our agencies support have a wide range of support needs, and my members, CPNRI members, have devoted the last 40 years to ensure community access and support is available. I believe the topic being reviewed today warrants the conversation that is occurring, and it was a very rich dialogue, and I appreciated it. I personally have spent the last 20 years learning about the system that serves individuals with developmental disabilities because my life was touched by it when my son was born with profound disabilities in 2000. As a parent of a child with a disability, I feel it's important to center my comments first about the lives of the individuals it will impact, what we're talking about today. While the facts and the data must guide our decisions, as the good senator will always remind us, I always want to ensure behind that data and facts, we are focused on the human story that tell those facts and data. My son's life was meaningful, his journey was fulfilling, and he had a purpose, as we all do. He lived at home with my family with clinical and community support. Each and every person who is living at Eleanor Slater Hospital, Zambarano, Adolf Meyer, Regan, Benton, their lives have meaning and purpose. Many individuals we are discussing have families who will be impacted by these decisions that are made and undoubtedly are wrought with angst and wonder of what is to come. This conversation deserves our attention and commitment at all levels to ensure we are making the decisions in the best interests of those individuals and their civil liberties, and we do so swiftly. What we are talking about today are the lives of some of the most vulnerable within our society. We must remind ourselves of our duty to honor and respect those lives and their civil rights first and foremost. As we move forward to contemplate what Eleanor Slater Hospital is or should be, we must center this conversation and decision around the belief that all Rhode Islanders are afforded integrated, meaningful life within our society. While we know some individuals will require and thrive in a very intensive institutional model of support, we know the vast majority benefit from a robust community-based support model. Not only do they benefit, it is their right to have access to it. You may hear from those who will say we need to ensure appropriate placement. We must follow a specific process. We need more time, which are all very reasonable statements. CPNRI would never disagree or object to those statements. We agree completely. But what we would like to say loudly and clearly is our collective responsibility to make policy decisions that address the root cause of the lack of community options that have led to long-term hospital stays at Eleanor Slater. The current system of community support has suffered from a lack of investment and clear direction for the last 2 decades. COVID-19 has shed a light on the fragility of the system that has been neglected at Eleanor Slater and within the community. We are now at a critical juncture. At a time when we should be doing more to promote and build community-based options, the workforce is at a crisis point. There simply is not enough alternative supportive housing, clinical step-down programs, or community-based models to meet the needs of those currently in the hospital setting. These are problems that have been persisting, but are completely within our power to solve. A few points I wanted to address that were addressed during some questioning of the Director Power. Not to be objectionable, but what I wanted to address it. I want to make sure our community is aware, and all committee members are aware, that families and community-based providers do support individuals with complex developmental disabilities, with complex behavioral health needs and medical conditions, ranging from trach and ventilated individuals to significant psychiatric disorders. It is not for a lack of ability or skill for community placement that discharges have not occurred. Our members are simply unable to take on more due to the lack of funding and investment in professional wages and programming to fully meet that need. Another point I'd like to make is the underpinning of the lack of continuum, again, is not for lack of commitment from the professional community. It is clearly a Medicaid reimbursement issue that has not had investment. If we are to ensure access to an integrated support model for individuals with intellectual and developmental disabilities and those with behavioral health conditions, we must take steps to stabilize and rebuild the community-based system. This is not only the right thing to do, it is our duty to do so, and do so quickly. The state has the opportunity to invest and to strengthen the community-based system, either public or private. It can and should be done. We cannot simply say it is our ideal. We must invest in it and take steps towards building it. Thank you for the opportunity to speak today.
Tina, thank you very much. Obviously, you're certainly well versed in this. Thanks for your leadership with CPNRI and all the other areas in which you've been involved. And clearly, you come to this with the direct family experience that many of us have no appreciation for, but you clearly are able to articulate that and communicate that message very succinctly. Any questions for Tina from the committee? Tina, thank you very much. Much appreciated. Have a good night.
Thank you, Chairman.
Thank you. Stand by for our next person to testify.
Hello?
Hello, Dr. DeSales?
DeSales, yes, thank you. Thank you, Mr. Chairman, and Senator Dela Cruz for this invitation. I'm Dr. Norm DeSales, the newly retired medical director and physician administrator at Zambarano between 2000 and October of 2020. I'm board certified in internal medicine and a graduate and a faculty member of the Brown Medical School, and I devoted 27 years at Zambarano, and I chose to retire several years early because of the administrative behaviors I witnessed at Eleanor Slater Hospital. I've been asked to describe the patients at ZAM and to provide my insights into what has been a guarded administrative subject. My insights are based on personal experiences, however, and only really properly conducted investigations will confirm or refute what I say. I'm here today really as an advocate for many voiceless and incapacitated patients and their families at Eleanor Slater. I refer members of this committee to my open letter of March 2nd, published a few weeks ago. When I started at Zambarano in 1987, the census was about 200. When I officially retired last month, it had dipped below 80 patients. In the past year alone, we'd lost more patients due to the administrative closure to new admissions, ongoing discharge, and deaths. The vast majority of ZAM patients come from acute care hospitals throughout Rhode Island. I have visited, assessed, and accepted patients from every hospital in our state. We don't admit out-of-state residents. Some patients come from nursing homes where their staff have realized their inability to meet the patient's medical and behavioral needs. The average patient at Zambarano is in their 40s. The average length of stay is months to years, depending upon their conditions. Some come from the LAD school, the LAD center, and have been institutionalized since birth. These folks are now in their 60s. Overall, the Eleanor Slater patients are divided into two units, the psychiatric unit in Cranston and the medical at Zambarano, with the exception of the ventilator unit in Cranston for numerous safety and mechanical reasons. Patients came to Zambarano because of permanently life-altering medical and physical conditions, such as traumatic brain injuries from gunshot wounds or accidents of all kinds, spinal injuries, degenerative diseases, brain injury due to drug overdoses, which have significantly increased due to the opioid epidemic, and those with paralysis of all four extremities, dementia with aggressive or self-injurious behaviors, and patients requiring inserted devices of different kinds. Zambarano is also a provider of advanced wound care for patients with debilitating pressure ulcers and bone infections acquired in other facilities. And most of them do not have physical or cognitive capacity to self-preserve or self-advocate, and most of them cannot speak. The majority of patients discharged from Zambarano go to nursing homes. This may occur after the reason for admission is resolved, like wounds have healed. The other scenario is that they go to nursing homes after they get worse and they can no longer benefit from our services. For example, they have repeated strokes and are no longer able to participate in or benefit from rehab. Other patients are discharged to group homes. These folks have non-psychiatric behavior problems caused by their underlying medical conditions. And nursing homes are unable to accommodate verbally abusive, physically aggressive young adults because of the harm they pose to others. Our goal at Zambarano is to find the proper therapeutic mix of activities, therapies, environmental cues, and medications that permit their success in a group home. Rare patients go home with family because they require 24-hour care. Even with access to all available community resources, success with family is infrequent and usually short-lived. The services at Zambarano simply do not exist in Rhode Island nursing homes. Trauma patients could not receive a regular program of physical, occupational, or speech therapy in a nursing home, nor could they receive respiratory therapy, which is essential for many. Care for debilitating pressure ulcers and bone infections do not exist. These services are vital if our young adults are to have any hope of returning to the community. In contrast, and this is very true, there are numerous Zambarano patients whose needs could be met in a nursing home. These patients, however, have circumstances that prohibit nursing homes from accepting them. And I'll give you some examples. History of elopements, combativeness, undocumented immigrants, sexual behaviors, suicide attempts, murder convictions, lack of a legal guardian, setting fires, the need for court intervention for permission to provide required care. These are real-life reasons why some patients are not accepted by nursing homes. And while it is true that this group of patients does not require hospital level of care anywhere, Rhode Island does not have that continuum, that intermediate level of care between nursing home and hospital, which I refer to as a nursing home or a group home on steroids. These facilities do not exist in Rhode Island, and the result is that these patients are forced into the least restrictive environment in Rhode Island that can accommodate their needs, specifically Eleanor Slater. In the spring of 2020, hospital administration usurped the normal patient discharge process and imposed its authority over the multidisciplinary team process in an effort to expedite discharges. The hospital's interests had taken over the patient's interests by hijacking the discharge process. Their efforts failed, though, because physicians could not responsibly sign discharge documents for patients who did not have safe discharge options. When Jennifer White, the acting CEO, called me to press me that, quote, 100%, unquote, of all patients needed to leave, I repeated the lack of safe discharge options, to which she replied, quote, then they can all go home, unquote. In my professional opinion, converting Zambarano to a nursing home would be a major error. It may lift the hospital's budget to safety, but it will throw voiceless, vulnerable Rhode Island residents overboard. A nursing home would not only provide less needed care to medically complex young patients, it would also obligate physicians to transfer some to out-of-state long-term hospitals such as Vibra Hospital in New Bedford. If physicians cannot access the care patients need here in Rhode Island, they will move them to that care in other states. Doctors do not have the luxury of undertreating patients. After 37 years as an internist and geriatrician and 20 years as physician administrator, I know there are patients requiring long-term medical hospitalization frozen in hospital beds throughout Rhode Island right now because no nursing home can accept them. Eliminating Rhode Island's only long-term hospital is one step forward for administration and its budget, but one giant leap backward for Rhode Island healthcare. If the ultimate goal is to eliminate long-term hospitals nationwide because they are expensive, then a thoughtful plan to integrate patient needs with providers in the community must occur before Eleanor Slater is closed, not after like we are seeing today. Smooth transitions of care could then move forward. In stark contrast, I continue to learn every day about administration gaslighting the staff and the public via Randall Edgar, while in reality gutting Zambarano and forging forward with irresponsible actions that put the safety of current patients at unnecessary and preventable risk. Staff are prohibited from speaking freely because of the threat of termination. And I would recommend that this committee hear from acute care hospitals in the community where long-term medical patients are now frozen. At this point, I'd like to move quickly over to my next most important point, which is the hospital's financial viability. I'd like to draw attention to the committee's attention to two documents. The first you've received already, which is the management consulting firm report from Alvarez and Marsal, and the second would be a CMS billing and chart audit conducted about 16 months ago. I don't believe that any document regarding the CMS audit has ever been released. Concurrent with the hiring of Alvarez and Marsal, the CMS conducted a billing audit. In late 2019, CMS cited the hospital for its continued lack of a mandatory computerized health information system, really a self-inflicted wound a decade in the making. The consequence of that citation is the loss of the hospital's ability to apply for and obtain federal reimbursement for care provided. The value of that loss is approximately 60% of the hospital's annual budget, or about $65 million per year going forward. Shortly after, in February of 2020, I learned from administration that they had abruptly developed urgency to stop all admissions and to discharge the, quote, 100% of patients. Administration then imposed unrelenting pressure on physicians to discharge despite the lack of a safe discharge plan. Meanwhile, some administrators acknowledged a shared fear that CMS would find billing errors in their audit and demand repayment for overpayments stretching back years, potentially placing the hospital in financial peril. Only unreleased documents will prove or refute that calamitous scenario has indeed come true. Not only is Eleanor Slater unable to earn federal dollars because of the lack of a computer system, it now also owes an undisclosed sum estimated in the tens of millions of dollars back to the federal government. Eleanor Slater has the potential to be insolvent. That begins to explain the aggressive and dispassionate administrative behaviors and actions that place hospital interests above patient interests. To disguise financial calamity by obfuscating in countless ways that Zambarano patients are the root cause is simply vile. We are witnessing unconscionable irresponsibility that directly and adversely affects patients. These currently impossible to prove insights raise several questions. Number one, why are a handful of administrators allowed to unilaterally alter a state-chartered hospital by gutting it into a nursing home even before it has such a license? Number two, is the conversion of Zambarano to a nursing home actually part of a CMS requirement in order to forgive the hospital's self-inflicted debt? Number three, if eliminating Rhode Island's only long-term hospital is the goal, why is it being done so secretly, urgently, and dangerously? Number four, why are high-risk discharge decisions being carried out in a vacuum without public planning or provider input before safe alternative facilities even exist? 2 physician layoffs and 2 premature retirements leave Zambarano with 2 physicians total, 1/3 of its medical staff. Administration also plans to eliminate 24-hour in-hospital physician coverage soon, leaving the hospital without any physician on-site nights and weekends for the first time in more than 50 years. This cost-cutting maneuver is irresponsible and dangerous. Although eliminating physicians would surprisingly not violate any known hospital regulation, It would violate the community standard of care for hospitals in Rhode Island and nearby Massachusetts and Connecticut. Lack of an on-site physician does occur in isolated communities of the United States with provisions for that, but this does not occur in Rhode Island or neighboring communities. Such brazen service reductions that adversely affect patient care signal an administration in desperation. The cost to the state of just one Sentinel event could easily eclipse any financial savings many times over. I call upon the legislature, the governor, and the Rhode Island Department of Health to exercise their authority to halt the administrative debacle that the medical staff has witnessed to allow full, deliberate, and thorough investigations to chart the best path forward. And I turn back to the chairman.
Doctor, thank you very much for being with us for so long, and thank you for your detailed testimony. Much appreciated. Any questions?
My apologies for going so long.
No. We appreciate your detailed insight in your years, and thank you for your years of service to the state. Questions from the committee for Senator Archibald?
Yeah, thank you, Doctor. First and foremost, listening to you is extremely enlightening, and you just, with all of your decades of experience, there's youth in your voice, but I'm inferring that you're probably close to moving on to your retirement. Not that I want to get you out the door anywhere too fast, because your empirical knowledge, the experience that you have, is second to none. And so I'm sitting here listening to you, and I'm taking nothing away from the prior testimony, but I'm thinking, before I wrote down some of the questions that you just asked, why isn't someone like the doc at the helm? Why aren't you at the top helping to make these learned decisions, and not people who are in an administrative capacity, no disrespect intended, but who don't have the experience, the medical experience, to make sound decisions that are going to trickle down to the care that's necessary for people in this unique facility, truly one of a kind in Rhode Island. It's not a nursing home. It's not a prison. It's a place where we can give people help that they need. So, with that said, I'm troubled that only a handful of administrators are making decisions that seem to be beyond the scope of their skills and ability, particularly when it leads to, high-risk people existing in this vacuum. And as you said, we're down to a third of the medical staff, cost-cutting maneuvers that are dangerous. We have a standard of care that's not being given, and a lack of on-site physicians. And you ended it with what can be done to stop it. Legislatively, help me as a layman. I'm a legislator. I'm not a doctor. I'm trying to wrap my hands around the issue. What specifically can we do? How legislatively can we address this tragedy that's occurring here? Help me, please. Help us.
I think that the governor may be able to help halt this process to allow for a much more deliberative, integrated discussion that would allow the facility to move forward in a much more organized way. Now, I listened to the director's comments, and there's very little that I could disagree with. Everything sounded very appropriate, very reasonable, and nobody could dispute. Virtually 99% of what she said, I could agree with. That does not, however, match my reality of what I see. And so her comments, I know, are very sincere from where she sits. My comments also, although very different, are also equally sincere. I love Zambarano. I worked there my whole career. I am here to advocate for those patients. That is my purpose, and that's why I'm here. They cannot talk for themselves. That is my goal.
Doctor, thank you very much. Senator, thank you. We do need to move.
Thank you, Doctor.
You're welcome. Thank you very much. Have a good night.
Thank you very much, Doctor, for being with us. We're going to move along to our next person who will testify. We're connecting with Pam now. Pam?
Yes.
Pam, welcome to the Senate Committee on Rules or Oversight on Eleanor Slater Hospital. You're on, we can hear you now.
Okay, thank you.
You're welcome.
Hi. Can you hear me?
Yes, we can. Go ahead, Pam.
Okay. Hi, my name is Pam Costello.
You can continue, Pam.
All right. My name is Pam Costello. I am calling in reference to my son. My son is currently a patient at Zambarano.
Okay. Would you like to come talk to us?
All right. As a family member, I would like to testify in support of Zambarano. My son, Jason, at the age of 22, in 1996, had a single-car accident. He received a traumatic brain injury at that time, pretty severe. His brain actually shifted, so one side disconnected from the other. We had him at home, I would say, 8 to 9 years on and off in between. He was in nursing homes. He was in rehabs. And eventually we got to the point where we got him into Zambarano, mostly because I'm getting a little older to be able to take care of somebody who, with his needs. Jason, at this point, can't perform any personal cares on his own. He has violent outbursts. He'll swear. And normally it takes at least 2 people to manage him through just getting cleaned up and getting dressed. The one thing I found at Zambarano is he's happy. They know him. They treat him well. He has no skin outbreaks. Range and motion, they exercise him. And they take very good care of him. And there's things they've said to me that I know he can do that they'll figure out he can do. So I know they spend a lot of time with him. They sing with him. They talk with him. In fact, Dr. DeSales was the doctor that studied his case and got him in there. So I think if Zambarano became more of a nursing home, he definitely would not be appropriate for that. There has to be staffing and medical professionals that understand his condition and how he should be approached. The last time he was in a nursing home, they called me and said, if you don't get him out of here soon, we're going to send him to the hospital so they can medicate him, and we will not take him back. So nursing home is not equipped to handle someone in his condition. I just trying to figure out what else I should say. They're a wonderful facility. They're on the water. He has a good quality of life. I'm always kept abreast of what's going on with him or if something happens. The fact that I'm hearing you're cutting down staff makes me very nervous right now, but to this point, I'm very happy. I mean, even his ears are clean. He's always smiling and laughing when I get there, so I know they take good care.
Pam, thank you very much.
I think that's it.
Pam, thank you very much for being with us. Thank you for the testimony. Sorry to hear about Jason. Hopefully things will, he'll continue to get the needed care that he has been getting as we go forward. But thank you for being with us tonight and to share your story. It's appreciated. Thank you.
All right, thank you.
Have a good night.
Bye.
Stand by, folks. Sharon?
Hello?
Sharon, can you hear me?
Yeah.
Thank you, Sharon. Thank you. Welcome to the Senate Oversight hearing on Eleanor Slater Hospital. The floor is yours.
Yeah, I was just, I don't have any direct, can you hear me?
Yes, we can. Yep.
Okay. Yeah, so I don't have any, like, direct correlation with Eleanor Slater, Zambarano, or anything, but my daughter, she has a severe cerebral palsy, so we have a in-home nurse who actually had worked there before, and because I'm, still kind of new to all of the things that have to do with having a child with a severe disability. So, and I'm also someone who always kind of like looks to the future of like, like what's going to happen down the line. And like, I like to be prepared for things and stuff like that. And one of the things that I was unprepared for, a while back was the closure of Memorial Hospital, which happened. And then I just had heard about this, and I was just immediately like, oh no, because it's, for me, knowing that something like that exists, makes me, I'm sorry, what?
No, keep going. That was somebody else getting in.
So, but anyway, so I looked into it a little bit just because I was like, oh no, like, like what is going to happen? Because I also work, in Providence and stuff, and I see, a lot of issues that arise from kind of like, group home settings and stuff. And I've been in personal situations within family members where people who have been in, facility like, Eleanor Slater, Zambarano and stuff, who just kind of end up doing like a circle around, once they get taken, once those like long-term care facilities cease to exist, and they just go into a situation where they're, in Rhode Island Hospital for 3 days until the insurance company says you're fine, and then they kick them out, they go over to this new thing, and then they circle around back to the same facility. So I can foresee that happening. I mean, I know that, everybody's doing their work as far as, seeing what the outcomes for a lot of these individuals are going to be. But I know from hearing stories from like recently, since February of 2020, just having the issues of people not having a place to go, and that being a very big concern, not just for people that are directly impacted because of their family members, but just in general, not having a safe place for some of these individuals. I mean, traumatic brain injury is something that like my daughter would be under, but it's, end-stage multiple sclerosis, Huntington's, and toxic brain injury, quadriplegia, and aggressive or self-injurious behaviors, and I don't know what other hospitals exist where they have, a 24-hour care service for them, but it seems like I'm sure that this is not rushed, that this is something that you guys, that has been in process for an extended amount of time that maybe the public just was unaware of, like myself, but for me, like, it just kind of seemed like it kind of like came up. And I know with like Memorial Hospital, it's one of those things where like, I know that me talking about this, it doesn't really have anything, any kind of dance in it, but it's just, it is for me a concerning thing. And I know that the decisions have probably already been made, but I really feel like this is going to be bad for society on various levels, and it goes in from the people that are actually directly impacted, with the individuals that are actually there, to the families and trying to, administer and figure out care, to the people where these people are going to be placed, and like the outsourcing of care. So I just wanted to say that.
Sharon, thank you very much for your testimony. As you may have had earlier, not that you needed to be around the entire time, but we've been around for about 2.5 hours. But the hearing is to determine what are the facts, what is the data surrounding Eleanor Slater Hospital, what do we do moving forward. So thank you for providing your testimony. Nothing's been decided categorically about what the next steps are, but this testimony will be critical as we move forward. So thank you for being with us tonight.
I appreciate it. Thank you.
You're welcome. Jim?
Good evening, Chairman. How are you doing?
Good evening, Jim Senarini. Thank you for being with us. It's over to you, Jim.
Okay. Thank you so much, Mr. Chairman, members of the committee. My name is Jim Senarini. I am the lobbyist for Rhode Island Council 94, the American Federation of State Commonwealth School Employees. I've been listening rapidly to all of the compelling testimony tonight. Council 94, and AFSCME specifically, has aggressively been at the forefront of lobbying on behalf of the Cranston campus of Eleanor Slater Hospital. We represent over 412 employees who provide direct patient care, dietary needs, housekeeping services, administrative, fiscal, clerical work, laboratory services, and facility and maintenance resources at the Pastore Medical Complex in Cranston, Rhode Island. My knowledge of the hospital is certainly not as detailed as Director Powers. I wouldn't claim to understand as much about Medicaid nor Medicaid billing, but I have some familiarity with the hospital since I've been lobbying to try to preserve what I believe to be the critical services that Eleanor Slater Hospital provides as the provider of last resort. I've been engaged in that fight since 2002. One thing that I think is important to point out to the committee in this time is that the hospital itself, since I've been lobbying for Council 94, has always been a sought-after treasured resource. The employees we represent care deeply about the patients who live at the hospital. For the Cranston campus, many of those individuals are court-ordered, whether it is civil orders or whether it is not guilty by reason of insanity orders that are sent to the forensic unit. Our members take great pride in providing an excellent level of care to some of Rhode Islanders who need the most complex forms of care. One thing that I think needs to be pointed out is back in 2002, when we started this fight to keep Eleanor Slater as a viable provider of last resort, Eleanor Slater Hospital regularly would pass JCO with flying colors. In fact, prior to the time when JCO decided not to score the hospital on a percentage basis, Eleanor Slater Hospital at one point was the only hospital to receive 100% JCO score. Additionally, the hospital had received awards for having what was called a zero decubitus rate, which that means for long-term patients they did not develop bed sores. Today, the hospital still provides an excellent level of care, but has suffered from a lack of investment. Getting to a point that Chair DiPalma pointed out, this was not supposed to happen. Back in 2014 and 2015, the General Assembly approved a substantial amount of funding. First it was $40 million, then I believe it went as high as $60 million, to build a new hospital at the Cranston campus. And the plan was really to address the complex needs of the patients. The union had advocated for years for the increased need for step-up and step-down units, and the fact that many individuals at the ACI could be treated more appropriately, in our belief, at the Pastore Medical Campus. So the union was ecstatic, the members were ecstatic that the new building was going to be built. There was still a path forward for Zambarano as well. Council 94 has never advocated that Zambarano should close. We've always maintained that there was a viable path forward for both institutions. Unfortunately, times changed. The shovels never got in the ground, and subsequent directors of Buda scrapped the plan that had received approval from the Department of Health. The money went unspent, except it was diverted into a number of high-priced consultants, most prominently Applied Medical Systems, in which the state spent over $3 million to study the issues facing Eleanor Slater Hospital. One other thing I would just like to add is Council 94 is proud to have been a foreleader in the deinstitutionalization movement. What seems to get lost all the time about the closure of the Ltch school is that the union itself, specifically Local 1293, worked extensively to help individuals get into the community, into community-based group homes, and also into state-run group homes. It just seems troubling that from everything I've talked to, many of the individuals who are personally involved in the deinstitutionalization, who they talk about all of the collaboration that occurred back then with Dr. Carl and many different individuals who are no longer in state government. And it just seems, and it gets to the first point in our written testimony, that there really has been a lack of communication or a lack of discussion with the employees themselves. Yes, there have been some town hall meetings that Director Power has held, but the information conveyed in those meetings is not always accurate. And one thing I want to bring to the committee's attention is just before the Alvarez and Marzel plan was released, Council 94 had been under the impression that there was going to be a path forward, and this was conveyed by the administration. There was going to be a path forward for both Zambarano Hospital and the Regan building. There was a consensus that the Adolf Meyer building would need to close. Much to our chagrin, when we received the actual PowerPoint, not the complete plan, but just the PowerPoint, we were really surprised to find that now the plan had shifted, that the Regan building, the Adolf Meyer building would be closed, and the only thing left would be the forensic unit at the Benton. Council 94 voiced our strong objections, much to no avail. I know that our local union presidents have suggested changes. Those have somewhat gone on deaf ears. So one thing I would like to point out to the committee is Council 94 is more than willing, and asked me in particular, to negotiate to find a way to alleviate some of the cost features or challenges that are facing the hospital. But we maintain that the Regan building, which has had a long tradition of providing an excellent level of care, should be provided a path going forward. One thing that has come to our attention is we at Council 94, and AFSCME in particular, represent the individuals who compose the billings that are submitted to Medicaid and CMS for approval. And we have struggled to obtain a clear, cogent answer from the administration. Yes, they tell us that there is an issue with Olmsted. Yes, they will tell us, oh, the model needs to change. But no one will provide us a particular answer as to why the billing methodology that Director Power was there when it was created, was used in effect for many years and was built and reviewed by CMS and approved multiple times, why that has suddenly stopped, where billing has just absolutely, completely been stopped. In fact, I talked to someone today who verified that the monthly billings are still compiled, but then they're never submitted to CMS. Now, the department will say, most likely, that when challenged on that they are still waiting for the state plan amendment and the rate methodology to be approved. I certainly am not an expert in this, but I would ask the committee to inquire why the rate methodology has not been approved. I've watched different state plan amendments just from the sidelines be actually compiled in some very difficult times, submitted, reviewed, and approved. It boggles the mind that a rate methodology, at least from my lay perspective, has been submitted to CMS where the hospital could be claiming some type of funding back from the federal government, and it's stuck somewhere. I also would just respectfully point out to the committee there's a series of detailed questions. One thing that I would like to point out to the committee is that while this started as an IMD mix issue, an IMD mix, which is that the hospital was never supposed to go above or exceed the ratio of more than 50% psychiatric, that that issue has not really also been fully examined, because while it started as IMD, I believe that Director Power testified that that was rectified relatively quickly. So we're months now later in this process, and from our understanding, the billings have not resumed. We would point out that the closing of the Regan building simply does not make sense to us. For many of our long-term patients, it is their home. We have housed the vent beds in a central location, that being Cranston, which is convenient to the families, members who have their loved ones there. It makes no sense, at least in the union's mind, that the vent bed should be moved to the northern end of the state and away from the center of the state. We also would point out that we are starting to become skeptical of the administration because of the massive amounts of funds that they have been spending on private consultants. For those who have spent a lot of time or around Senator Chacon, much to his credit, he has devoted a lot of time to identifying private consultants. Some may recall the $102,000 a year typist that Senator Chacon unearthed at the Department of Transportation. Unfortunately, what the union is worried about is we now have invested up to $1.5 million with Alvarez and Marzal for Eleanor Slater, another $900,000 to talk about the privatization of RI-Class, and I forget, it might be over $1 million that was invested for previous work at DCYF, and then they were also temporarily awarded a no-bid contract at Rhode Island College, and when that came to light, that was quickly withdrawn.
Jim, if you can...
Alvarez and Marzal has an impressive resume, but let there be no mistake about it. Our international union, which has a full department of labor economists, provided our second handout, which is a deep dive into Alvarez and Marzal, as well as to the plan that they put together. It raises many legitimate questions. Most pertinently, that Alvarez and Marzal is primarily a corporate turnaround specialist that advocates for the implementation of private equity into the healthcare system. I personally think that it's a completely inappropriate model. I would urge the Assembly to use their discretion to really thoroughly review these plans, and I'd be happy to provide more detail on that.
Jim, if you can wrap it up, please. Thank you.
Yep.
I appreciate it.
We also would point out that for our members, Local 1350 is one of the most ethnically and racially diverse in Council 94. Our members also live in many of the urban rings. I know that the department has talked about preserving Burrville jobs, but our members are justifiably concerned about their livelihoods. And I would just close by pointing out that the lack of dialogue with the state has been extremely troubling. We have asked for answers. We have been rebuffed. We have asked for documents. We have been rebuffed. And I would just point out that in our contention is that the state has been failing to live up to their obligations of their contract with us, and there are still many unanswered questions about the use and how this may impinge upon the privatization of state services. One thing just that we took great pride in is that the General Assembly enacted that law, the privatization of state services, when Governor Kachuri attempted to privatize the dietary and housekeeping at Eleanor Slater.
Jim, if you can summarize, please.
Hope you will use the same amount of discretion in examining this plan, which we think is flawed. And one last thing, there was something that Director Power mentioned where all of the discharges were successful. I would direct people to the Providence Journal article, "The System Failed Her," February 26, 2021. I'm sensitive to HIPAA, but at least one discharge I know was not successful. And I believe that when a family member inquired of a private medical provider if the resident could return to Eleanor Slater, was told that not by Eleanor Slater itself. It was told by the private provider that admissions were closed.
Jim,
so
if you can,
I think a
Jim,
lot more attention needs to be dedicated to this plan.
Jim,
thank you so much.
Jim, thank you very much. Much appreciated. For folks who are still watching who we haven't called yet, if you can please work to the objective of 3 minutes, threshold of 5. We still have 16 folks to go. Hang on, folks. Next person will be joining us in a minute. Just stand by, folks. Stand by, folks. Good evening, Matthew. How are you tonight?
Good evening, Chairman, members of the committee. My name is Matthew Gunna. I am president of SEIU Local 580. We represent clinical social workers and psychologists at the hospital. We also represent caseworkers that work with clients with developmental disabilities who are not at the hospital. Thank you so much for your commitment to covering this important issue. I will be brief. I just want to highlight, taking issue with the Director Power, taking issue with Dr. DeSalle and his openness to communicate transparency to the system. Because I can tell you, for members and workers at the hospital, they did not take issue with that. They were very happy that transparency was brought to the table on these issues and concerns that frontline workers have at the hospital. I would agree with the previous testimony that there's lack of communication and lack of input from direct care staff in how administration makes decisions. I believe the hospital has a lack of capacity of civil commitment, as outlined regarding the recent media story. So the incident where there was a crime committed and that patient had to be readmitted to the hospital, only received that hospital care from the state hospital because crime was committed. Those patients that need support that the state hospital should be providing are basically being ping-ponged from Rhode Island Hospital, the Butler Hospital, the Fatima, and they're not getting the long-term treatment that they need. The director had mentioned that the system lacks a robust community support model, but at the same time is changing discharge procedures to expedite discharge to that same insufficient community support model that she admits today is in place. So I appreciate the committee asking those detailed questions. I just want to highlight that part of the problem is not only insufficient reimbursement from Medicaid, it's also insufficient reimbursement to providers of private insurance companies. Private insurance companies' loan reimbursement rates create the market in which highly regarded mental health providers in the community will not accept insurance at all. They only take out of pocket. So that's a huge issue. Lastly, I just want to say that our caseworkers that are part of the continuum of care, that work with developmentally delayed clients in the community who work at Buddha, their caseloads are so high, between 150 to 200 clients, that they're only seeing their clients approximately once a year. And now with COVID, many of those clients they haven't seen for over a year. So that just speaks to the lack of a robust community support model, and continuum of care we have in Rhode Island. We used to be a model for the nation back in the 80s and 90s when we had a robust community mental health support system, and we don't have that. So I do believe that's part of an overall solution. However, the fact that discharges are being made, which appears to be financially based versus client based, needs to change. And I appreciate again the committee paying attention to this important issue. Thank you.
Matthew, thank you very much. Thank you for being here tonight and for your testimony. Much appreciated. Before we go to our next, Senator Archibald, with a quick comment.
Chair DiPalma, may I make a quick comment before the call?
Go ahead, Senator Archibald. Sorry.
Yeah, thank you. Just a few seconds here. That last caller from the SEIU, first of all, I appreciate them and everything they do greatly, but I think he's hit a nail on the head here. And Dr. DeSelle's testimony clearly showed that the level of care that this facility should receive isn't there. And after listening to Jim Senarini, who I know and respect greatly, and some of the frustrations that he sees in the administration of that care, decisions are being made that don't seem to be in the best interest of the people at that facility. And I'm going to be bold in saying that. I think we need another hearing perhaps after this where we dig in a little deeper and try to figure out some type of government oversight solution that we can craft here and work with the governor's office to try to find a remedy. There's a problem here. And anyways, I'll stop.
Thank you. Thank you, Senator.
Thank you.
Jamie, to the next caller. Megan? Meg?
Hi, yep.
Thank you for being with us tonight. Welcome to the Senate Committee on Oversight on Eleanor Slater Hospital. And I'd ask if you can try and finish in 3 to 5 minutes, it would be appreciated. Thank you.
Absolutely.
Over to you. Thank you, Meg.
All right. Thank you, Senator DiPalma, and I thank you very much for holding this critical oversight hearing, and I thank everybody who's testified so far. I have to say I pretty much agree with everything that's been testified to by the witnesses that have testified. My name is Meg Klingham. I am the director of the Office of the State Mental Health Advocate. As the mental health advocate, it's my statutory duty to represent and protect the civil rights and liberties of patients at Eleanor Slater Hospital. Part of those civil rights and liberties are that people who are at Eleanor Slater Hospital receiving treatment have the right to individualized treatment plans necessary to provide the care and treatment that they need for their disabilities. I'm going to focus briefly on the Cranston campus as my purview is the psychiatric patients. Just to clarify, there are forensic patients that's in the Benton building. That is the service that is anticipated to remain open. But there's also a number of civil psychiatric patients at Eleanor Slater Hospital in the AM building and in the Regan building. As of March 1st, there were 59 civil, that is non-forensic, psychiatric patients at the Cranston campus. Those patients are a mix of voluntary patients, that is patients who have signed themselves into the hospital and are receiving treatment on a voluntary basis, as well as patients who are court-ordered, meaning they are ordered there by the mental health calendar of the district court after a finding that they are unable to be in any less restrictive setting based on their psychiatric needs, and that they need a hospital level of care because without that they would be a danger to themselves and to others. I point this out because there are at least a couple of dozen patients at the Regan and the AM building who have been ordered there by district court justice sitting on the mental health calendar after a full hearing wherein testimony was presented by Eleanor Slater doctors who are treating these patients, testifying under oath that these patients require a hospital level of care. I agree with Director Power and I agree with the testimony that's been presented so far that we need a more robust system of services in the community that's been neglected for years and years. There are some patients that are at Eleanor Slater Hospital right now who would be able to be treated in the community and have a less restrictive environment. Were that to exist, But as I think Senator Miller put it, we're putting the cart before the horse here because that robust system of services does not exist. Any contemplated closing or reorganization of Eleanor Slater Hospital needs to be preceded by a needs assessment and an investment into the community so that there are places that people can go. Unfortunately, though, even if we have the most robust system of care in the community that we could have, there are always going to be some patients that require the very highest level of care. There are patients that are refractory to treatment, meaning that despite all of the treatment provided to them, all of the medications, all of the therapy, all of the medical attention, their illness is such that they are not responsive to treatment. They're still highly symptomatic, and they need to be in the highest level of care. And for us, that is Eleanor Slater Hospital. I have to take issue with the director's assertion that all of the discharges have been successful. I won't get into details, but as other people have testified and as we've read in the media, there's one extremely unsuccessful discharge that occurred where not only have people been victimized and displaced from their homes, but now this person who was discharged without, I won't comment on the details, is subject to life imprisonment now. This is a person who had lived and received services at Eleanor Slater Hospital, who not only allegedly victimized all of these people, but now she herself is facing life imprisonment after her discharge from Eleanor Slater Hospital. So before any effort is made to discharge patients, we need to first assess who actually needs that high level of care, and second, plan for what's going to happen in the community so that people can receive the services they need. Now, I stated that there are approximately 59 civil patients right now at the hospital. I think it's also important to note that that number is somewhat warped because Eleanor Slater Hospital, as far as psychiatric patients, has not accepted any admissions since approximately 2015. Very, very few admissions. So although there's 59 patients who remain there now, there could be more that need that level of care, but they have refused to take any admissions since 2015. I think a lot of people aren't aware of this, but there is also a long-term care unit at Fatima Hospital that has a capacity for about 20 patients. Those are patients, many of whom had been discharged from Eleanor Slater Hospital around 2016, that are still on the long-term care unit at Fatima because they've been unable to be discharged into the community. So there are patients that need this high level of care, and there are insufficient services in the community for people. We also have patients I have clients, patients, who are stuck in the community hospitals for 1 to 2 years on acute care units because they need a hospital level of care. They're unable to be accommodated in the community, and Eleanor Slater has not admitted them. So they're stuck on a unit at Butler, Rhode Island Hospital, the other community hospitals, for lack of a placement in the community. So there is the need for this level of services.
Meg, if you can
Excuse me?
if you can summarize, appreciate it.
So, to summarize, we need the highest level of care of Eleanor Slater Hospital. Before we can discharge people into the community, we need to invest and we need to determine what level of care, what level of services we need in the community, and we need to make sure that they exist before we start discharging people. Thank you again very much for paying such good attention to this issue and allowing us all to express our thoughts on this.
Meg, thank you very much. Questions for Meg? Senator Dela Cruz.
I just wanted to catch Meg's last name and the organization she represents.
So,
Continuum, and I am the mental health advocate.
Thank you.
Senator, if we were at the State House, you would have seen Meg walking around the halls. So, Meg, thank you very much. Thank you for what you do.
Okay, thank you. Bye-bye.
We're going to our next person to testify. It's Melissa? Is this Melissa?
Yeah.
Hi, Melissa. Welcome to Senate Oversight hearing on Eleanor Slater Hospital. I'll turn it over to you if we can try and keep it between 3 to 5
I'm going
minutes
to
would be
keep it
appreciated.
brief. I had a nice long thing, but I'm going to keep it nice and brief.
Melissa, thank you very much.
You're welcome.
Over to you. Over to you, Melissa. You're on.
Okay, thank you. You can hear me?
We can, yes.
Okay. So good evening, Mr. Chairman and honorable members of the committee. My name is Melissa Ferrario, and I am the union president in Age Local 79, which is the National Association of Government Employees. I represent all of the registered nurses at the Pastore Complex in Cranston, which of course is the Benton building, the Adolf Meyer building, the Regan building, also the Rhode Island Training School, and I also have members at the Rhode Island Department of Health. I want to start off by saying the nurses and staff at Eleanor Slater and Cranston provide the best care in the state to a very challenging psychiatric population, as well as those which are medically compromised and live by means of ventilation. Regan 5 is one of the best ventilated dependent units in our state. They take care of traumatic brain injuries, ALS, and young overdose patients, to name just a few. Regan 5 is 24 hours care, which includes respiratory therapists and nurses, which have special training in respiratory care. They have a Bernoulli system on the unit which notifies staff early of a deteriorating patient on a vent, and alarm sounds as well. The patients on the unit have never acquired a ventilator-dependent pneumonia, and also have rarely had acquired pressure wounds, which is also unheard of. The psychiatric population, as we know, and I concur with Jim and Meg in their previous testimonies, are the most difficult in the state. Diagnoses range from everything from developmental disabilities, schizophrenia to bipolar, just to name a few. The Benton building, as we know, are those that are committed, and it is no exaggeration when I say that the staff is assaulted on a daily basis. And you can ask anybody that can verify that. My other big claim here is I don't know why we're not taking admissions. We've stopped taking admissions since the fall of 2019. And some of these patients, some of these ventilator-dependent patients that are in acute care hospitals would right now probably be able to be billed. And it's very puzzling. Meg had already said that, on a daily basis, we get asked from other facilities like a Butler when we are taking patients again. And that, it has not happened. I also want to mention that the criteria for admissions now is unachievable to anyone outside. This administration has set a criteria that only an ICU level care patient could be admitted to the hospital, which is unheard of. So we wouldn't be able to take an admission if we wanted to. I also obviously concur with the EMR. We need to get an electronic medical record in as quickly as we can to get this billing done. And as Jim has stated, the unions, the direct care staff, we are not involved in anything at all. We are just as much as in the dark as everyone that works and the staff works. We get asked on a daily basis what's going on, and we have no answers. So that's pretty demeaning. The whole fact of the consultants, the Alvarez and Marcel, getting the money that they're getting, and I do believe, as one of the senators had said, I don't know exactly where their loyalty is. I don't think it's just a general loyalty. I think they're listening to others that are being a little persuasive. So, and as Jim said, the new building that is supposedly going to be built, they had already leveled a part of the Matthias building, which is attached to Regan, to put that new facility. That, of course, the money was allocated elsewhere. My other concern is when there is an issue with a Benton patient, as far as like a rehabilitation type of issue, or if they need antibiotics or IV medications and things like that, they would normally come to a step down like the Regan building. So I'm not sure where we're going to be sending them now. Are we going to be sending them to acute care hospitals? That just doesn't make much sense at all. I just want to say that both Pastore and Zambarano provide the best care to the patients. And in most cases, we are their family. I just ask that we, look at things. Obviously, we have to look at things fiscally responsible, and stay away from the politics of things. I encourage anyone who wants to come and tour Benton and Regan to please do so, because the buildings are in really good shape and aren't as bad. And I don't believe the, reconstruction or the construction of things. And there are a few datas in the Alvar and Marcel data that says, millions of dollars to do things that can be available. I believe, like Jim said, both buildings to stay open, Zambarano and Regan. And anytime that anybody has any questions, I would be more than happy to answer whatever I can. And I thank you all for the time, and especially the time for having this hearing on this extremely important matter.
Melissa, thank you very much. I think Senator Dela Cruz has a question.
I would love to take you up on that offer and tour the Cranston campus.
Sure. Just we'll reach out. We'll reach out to each other and get in touch. Absolutely.
Thank you.
Senator Dela Cruz, it'll be an experience. It will be. Jamie, we have a. Good evening, Marcia.
Hello.
Hi, Marcia. This is Louis DiPalma. This is the Senate Committee on Oversight on Eleanor Slater Hospital. Welcome to the committee. We're ready for your testimony. If you can please keep it to 3 minutes. Go ahead. Go ahead, Marcia. Over to you, Marcia.
All right. My name is Marcia Boyd. I have a family member at Eleanor Slater who has been there for a few years and is doing very well. As a family member, I wrote a 4-page letter that I will not recite in support of keeping Eleanor Slater open, the importance of the staff there, and further, I am a member of the National Alliance on Mental Illness, the Rhode Island chapter, and a coalition with the Mental Health Association, OASIS, and Mental Health Recovery, who have submitted a policy proposal authored by Lori Bashotti of the Mental Health Association concerning these issues. And we urge the committee to look at this. It raises a number of issues, many of which have been discussed tonight. I think one of our primary concerns is that the discharges at the hospital stop, and that there be a lot further investigation of this overall situation, which I think your committee has started a wonderful dialogue tonight. I have two things that came up during the hearing that struck me. One, speaking as an attorney, it was mentioned by the director that there is an appeal process. Our family has not been informed of any appeal process. Family has received a 1-page letter about the future of the hospital, but an appeal process hasn't been publicized. I'd like to find out where that process is written down, who developed it, how people know about it. There's a statement that it's never been used. I don't know if who knows it exists. Our group that put together our policy thought about that, and none of us were aware of a formal written policy of appeal or for a review of discharge. The other point was the interesting comment that all of the discharges, and Meg Klingam referred to this, have been successful. I was in a meeting maybe 2 years ago with some administrators at Eleanor Slater who were talking when a ward floor was being closed, who talked about the discharges, and I said, "Oh, how are you following up, and how do you know what's happening?" And the response was that they were not. I believe the 22 discharges that were referred to tonight have been in the past 6 to 12 months. This leaves out all of the prior discharges since this effort has started at Eleanor Slater. The other problem is that there are a number of folks, as has been referred to, who are now in hospitals, if they're lucky, waiting to get into Eleanor Slater. There are also newer, younger folks who are exhibiting and unfortunately developing serious mental illness who might need treatment there. And there is no place, they cannot be admitted according to the state policy. The persons who are not in the hospital waiting for the bed are victims of the lack of alternative treatment in Rhode Island. Some of them end up in homeless shelters. They're discharged from the hospital in a cab and sent to a homeless shelter. They end up on the street. There is no place to go. I have clients who have family members who are waiting in hospitals or are in substandard living, unsafe living. There is absolutely nowhere for them to go. I think it's very hard to understand this if you haven't been in the situation of talking with a family who's trying to find a place for their loved one to live safely and get treatment. Rhode Island does not have the facilities. It just doesn't exist. Yet they are moving people out of Eleanor Slater, not letting in new people who need it. And this is resulting in incredible hardship and even death. In my letter, I do reference a family member who did end up jumping off the Jamestown Bridge, partly due to the fact that there was no housing or place for him to go as a result of his conditions. And these are just some of the points that point to the fact that we need a much deeper investigation and a commission to look into this whole situation, find out how all of this effort started to close the hospital without having any replacement, and looking at the problem of stigma and discrimination against persons with mental illness. These situations simply do not arise with persons with other types of conditions. I'll try to stop talking, and thank you very much for having this hearing.
Marcia, thank you very much for being with us tonight and staying so long and waiting for that time. It is appreciated, and the committee thanks you for being here. Thank you.
My pleasure.
I think we have Lori on the line. Lori, are you on the line?
Yes, I sure am.
So is it Lori Marie Pisciotti?
Pisciotta.
Pisciotta.
Yes.
Sorry.
Good evening, Chairman DiPalma. Thank you.
Thank you. And Lori, thank you for welcome to the Senate Oversight hearing on Eleanor Slater Hospital. If you can please keep your remarks between 3 and 5 minutes, it would be appreciated.
I sure will.
Thank you.
Good evening, members of the committee. I'm the Executive Director of the Mental Health Association of Rhode Island, and I do promise to be brief. Thank you for this special hearing, and thanks for the opportunity to speak. We appreciate BHDDH and Director Power's efforts to build out Rhode Island's continuum of care, but we remain very concerned about what's been happening at Eleanor Slater Hospital. I would like to make a few specific requests to improve the situation. First, we heard in previous testimony that patients are not being forced to leave Eleanor Slater Hospital. However, the fact that a patient or their family member can appeal a discharge tells us that patients are either being forced to leave or they perceive they are being forced to leave. If patients really do have a choice, then we respectfully request a moratorium on disputed discharges, and we request that the state change the language of the, quote, discharge notice to reflect the fact that patients can explore alternatives or can stay in Eleanor Slater Hospital if they feel it is best. Next, I would like to address the issue of deinstitutionalization. It's true that Eleanor Slater Hospital is the most restrictive level of care, but it's an important and necessary part of Rhode Island's full continuum of care. The fact that it is restrictive does not make it an illegitimate option for some patients. Some patients with severe behavioral health and medical disabilities really do need permanent intensive care. So closing the civil commitment facilities at Eleanor Slater Hospital would only create yet another gap in Rhode Island's continuum of care. It must be noted also that in the Supreme Court ruling Olmstead VLC, the Supreme Court said that individuals have the right to receive treatment in the least restrictive setting when such services are appropriate and the patient does not oppose community-based treatment. Again, getting back to that issue of patient choice. In addition to the moratorium on discharges, we respectfully request that the state, number one, work with community advocates to create a transparent patient evaluation process at Eleanor Slater Hospital. Number two, please work with us to increase transparency, due process, and accountability in the discharge process. Number three, establish a living Olmstead plan that we've already talked about this evening. Almost every other state in the country has an Olmstead plan already. A plan would help us coordinate and fund the full continuum of care. Without a plan, we will never achieve our goals. Having a plan is the foundation, a foundational step toward truly fulfilling the aspirations of the Americans with Disabilities Act. And it just so happens that the Mental Health Association has already developed a proposal to establish an Olmstead plan in our state. And if this committee would like to review that proposal, I would be happy to send it to you. And lastly, as Marsha Boyd already mentioned, we have submitted to this committee a proposal for Eleanor Slater Hospital with some funding ideas that you can review at your leisure. We hope to partner with BHDDH and the General Assembly to find solutions to this crisis. And I thank you for your consideration, and I'm happy to answer any questions you may have.
Lori, thank you very much. We do have your written testimony. I plan to review it again. And any plans you have, if you can please send those along, and we can schedule a follow-up meeting to review that. But it's much appreciated, Lori. Thank you very much for being with us tonight.
Thank you. Good evening, everyone.
Thank you. Good evening, Chris.
Senator DiPalma, how are you this evening?
Very good, Chris. Welcome to the Senate Oversight hearing on Eleanor Slater Hospital. Chris, thanks for all you do, and thanks for being with us tonight. We ask if you can keep your comments to 3 to 5 minutes. It would be appreciated. Thank you, Chris. Over to you.
Will do. Thank you, Mr. Chairman, members of the committee. My name is Chris Colaci. I've come before many of you over the years. I'm General Counsel for the United Nurses and Allied Professionals. We're the largest healthcare union in the state. We've got members out at Zambarano, as well as in hospitals all over the state between Westerly and Woonsocket. I've listened to all the testimony so far. Let me say a couple of things here. We've got a statute on the books that is known as the reverse CON statute. I'm going to give you the site quickly, 23-17.14-18. And that statute says that if a hospital is going to eliminate or significantly reduce primary care services, they've got to get prior approval from the Department of Health. And they've got to submit a written plan, and there has to be public comment, all the things that common sense would dictate. Now, back in November 23rd of last year, we cited this statute in a letter to Dr. Alexander Scott, and we asked her to do the following. We said, look, would you please issue a cease and desist order, require that Eleanor Slater submit a written plan as to what they're up to, allow for public comment so that this thing can be properly vetted. And we asked her to advise us in that regard. We told her the time was of the essence. And by the way, even if the statute doesn't apply, would it not be prudent to hit the pause button and look at this thing before you just shoot first and ask questions later? Well, almost 4 months went by, not a whisper from these guys. On March 10th of this year, WPRI runs an article, and they reference our letter in the article, meaning our November 23rd, 2020 letter to Dr. Alexander Scott. And lo and behold, I don't want to sound like a smart aleck here, but 2 days later, on March 12th, we get a non-responsive letter of response from the Department of Health, referring back to our November 23rd letter. And I say it's non-responsive for two reasons. One, it took them almost 4 months to respond to our November 23rd letter. Two, I'm just going to quote from one section of it. Please know that the Rhode Island Department of Health is in the process of examining concerns related to discharges from the state of the hospital. Now that doesn't tell us a whole lot of anything about anything. And it's not responsive to our request for the issuance of a cease and desist order, or requiring the hospital submit a written plan, or to allow for public comment. So we really didn't get anywhere in terms of that response, which is problematic in and of itself. So on March 17th, we sent a letter back and said, we're disappointed. Your letter was unresponsive. You waited for almost 4 months. The letter itself doesn't tell us anything. We'd like to meet with you, Director. And we filed a formal APRA request. And the reason why we filed the APRA request is I noticed a recurring theme from the witnesses who have spoken before me tonight. And the recurring theme is a lack of transparency, an overwhelming darkness, a lack of sharing of information, and the issues that are being presented to this committee are of such a significant magnitude that there is no room for darkness and there is no excuse for being anything other than transparent. So I'll close by saying this. If you look at the statute, I think it covers this subject matter, and the Department of Health ought to stop this thing and vet it. If it doesn't, then maybe the committee can look at a way to make that statute cover this particular amount of subject matter. I'm happy to share these letters with you. I am happy to share with you whatever we get from an APRA request, and there ought to be a lot there, because I listened to the director's presentation, and if they've been doing all the work they've been doing on this, then there's a lot of information that they got to give us in response to that APRA request. So I'll yield to the committee at this point.
Chris, thank you very much for the work. Whatever you can send would be appreciated, and we'll get it to the committee. And I was going to ask you, are you sure you got the Rhode Island General Law citation correct? But I'm sure you do. So thank you.
All right, you're welcome. Thanks for the opportunity.
What I wrote down was 23-17.14-18, correct?
You got it. Subsections A, B, and C.
B. Chris, thank you very much for being with us tonight.
All right, thank you for your work.
Chairman,
Chris, hang on one second. Senator Archibald.
No, just a comment quickly. I remember Chris, and I remember his testimony a couple of years back on the hospital merger issue, and I was really impressed with his detail of analysis. And I mean, he's been living this stuff. He's been doing it his whole career. We really need to take that APRA information in, and if the Department of Health doesn't want to exercise the oversight, then perhaps we need to appeal to the Attorney General's office and see where that'll take us. We need some help here. We need to go on with another hearing. But anyway, just my comments.
And Senator Archibald, I think we'll hear from Chris next week on a different topic. Thank you, Chris.
All right, thank you. Good night now.
Thank you. Folks, we have about 6 folks left. We have Dr. Paquette coming up. Dr. Paquette?
Yes, thank you, Mr. Chairman.
Welcome
my name is Dr. Michelle.
Go ahead.
Can you hear me?
We can.
Okay, yes. Okay. My name is Dr. Michelle Paquette, and as a physician in practice for over 40 years, I've had the privilege of spending the last 20 years caring for patients at Zambarano Hospital. My comments will specifically address only the Zambarano patient population, as their needs are different from those of the mental health population. I'd like to give you some examples of the challenges my patients deal with on a daily basis. Many of them are paralyzed, able only to move their heads, but because of the services available at Zambarano, they can get out of bed every day and move around in power wheelchairs. Some can't swallow well or need special respiratory care, but because there's a sufficient level of staffing, they avoid choking, pneumonia, and early death. Some are developmentally disabled and might otherwise live in group homes, but because of their uncontrolled behaviors, they have failed those placements. These are only a few examples of the problems that face patients admitted to Zambarano. Zambarano Hospital was built to care for Rhode Island citizens with tuberculosis and has always adapted over the years to help those with difficult afflictions. Patients, families, and even other hospitals, as well as nursing homes, have come to rely on Zambarano to take care of people who have complicated medical and behavioral problems that can't be served elsewhere. Its focus is to help them have the best quality of life possible. Several months ago, the hospital administration began to dismantle Zambarano as we know it. Physicians have been laid off, rehab staff hours have been cut, patient activities have been curtailed, and new admissions have stopped, all while non-union administrative positions have been increased. I'm not so naive to think that this has nothing to do with money. In fact, money is probably the driving force. But instead of being transparent about the situation, administration attempted to have us as physicians say that the hospital is unnecessary. They asked us to tell our patients that they did not need Zambarano to provide the level of care they were receiving. In my professional experience, the level of care and the quality of life that many of our patients receive can't be found in today's available community settings. Unlike what has been presented, Zambarano has always discharged patients when appropriate options were feasible. There has always been a review of discharge options every 3 months. Despite the administration's comments, we as physicians have no issue with discharging patients when their needs can be met elsewhere. The patients who remain at Zambarano do not have realistic discharge placements. Administration keeps insisting that keeping our patients at Zambarano will cause them to lose life skills. I would counter that our patients would lose life-enhancing care if they were discharged elsewhere. We were also told that our current patients must be discharged because they do not meet hospital level of care based on BHDDH criteria. That last phrase, per BHDDH criteria, is key, as these admission criteria do not exist anywhere besides BHDDH. In fact, they are so stringent that if they were applied to the other hospitals in Rhode Island, those hospitals would all be empty. These criteria appear to have been engineered solely for the purpose of discharging patients from Zambarano. In fact, to support their assessment, the administration had to hire a traveling nurse to come in, review the charts, and declare that 100% of our patients didn't belong at Zambarano based on those criteria. And so, non-medical administrators continue to assert that our patients need to be discharged. They attempt to compel physicians to sign letters and forms attesting to the fact that the patients don't need this care. After hearing today's presentation by administration, I have several questions. Why was this approach chosen? Who changed the criteria for admission, and why? Why did they ask physicians to discharge all of the patients despite their own admission that appropriate settings do not exist? And finally, why are no new patients being admitted? Thank you.
Dr. Paquette, thank you very much for your testimony tonight. Much appreciated, and thank you for all your service to the state over the many decades. Thank you.
Thank you.
Hang on, folks. We had somebody. We got to call him back. We have 5 folks left. I appreciate the committee's indulgence. Good evening, James.
Good evening, Senator DiPalma. I appreciate you taking my testimony, and I will be as brief as I possibly can.
We appreciate that.
My name is Jim McNulty. I'm the Executive Director of Oasis Wellness and Recovery Center in Providence. We are an organization made up of people who live with mental illness. Among our membership are many people who have, at one time or another, been patients at Slater, at the mental health unit, both civil and also forensic. The reason I wanted to speak to you tonight is to focus on something. There's something that the Director of Power made a point of mentioning, is that there are some large gaps in the continuum of services, and that we need to fill those gaps. But closing down the mental health the adult psychiatric service at the Cranston campus doesn't make sense because we've got no place for these folks to go. The community mental health centers are not able to take some of these people. I've talked to several community mental health center directors, CEOs, and they say that simply enriching the MHPRR rate, the group home rate, is not going to solve the problem because that's not the right level of care. You need something more than a regular group home and something less than Eleanor Slater. Such a facility does not exist. There are other gaps in the system, many, and I'm not going to take your time up tonight to recite them. The director mentioned that Faulkner Associates is putting together yet another study for the department. At the Governor's Council meeting last week, I was quite surprised to find out that Faulkner had met with all of the stakeholders in the system, but they had never met with consumers of mental health services or family members. And they're developing a system of care without getting input from the community, which strikes me as really dangerous. If there's anything that I've picked up tonight from listening to this meeting, which has been going on since 5:30, is that there's a level of communication and transparency that hasn't really happened. And I know I've worked with Director Power for many years, and I'm very familiar with her. She's a very, very honorable person, and she really does do her job to the best of her ability. I don't think that the assignment that she's been given is exactly what needs to happen in terms of where the at least the mental health part of the system goes. I'm not competent to speak to the situation up at Zambarano, but I will say that I heard Tina Spears testify, and many of the things that she said about the DDID population also apply to the behavioral health population, and I would just refer you to that rather than to keep repeating what other points other people have made tonight. I want to thank you for your patience. I want to thank you for listening to us. It's very important, and it's important that you take the data that you get from this, the data that you've been pointed to, and make a determination. Senator Miller made a very important point that you may be getting the cart before the horse. I think there's something there. So with that, I'm going to say I think I've said what I need to say. I want to thank you again for what you do. And if there are any questions, I'm glad to answer. If not, I'll bid you good evening.
Jim, thank you very much for being here. Thank you for all you do and your input to the committee. Much appreciated. Thank you, Jim.
You're quite welcome. Thank you, Senator.
Have a good night.
Bye-bye.
We have 4 left, folks. Good evening, Richard.
Yes.
Welcome to the committee, Oversight Committee on Eleanor Slater Hospital. We're glad you're with us. Glad you stayed with us as long as you did. We'd ask if you can try and keep your comments or your testimony 3 to 5 minutes, but we want to hear from you. Thank you.
Thank you very much. Thank you, Mr. Chairman and honorable committee members. My name is Richard Demers, speaking to you tonight on behalf of my brother, Rainey Demers. Rainey is 63 years old and has been a patient at Zambarano Unit for 48 years. He was born in 1957 when he was diagnosed and operated on, when Rainey was diagnosed and operated on for the removal of a malignant brain tumor when he was 2 years old. The operation left him paralyzed from the waist down with only limited use of one hand and subcognitive limitations. After the surgery, he was cared for in our Woonsocket home by our parents and grandparents who moved in to help us out. By 1972, our grandparents had passed on. I had married and moved away, leaving my mom, dad, and Rainey in the household. That September, our dad, Adrian, suffered a fatal heart attack, leaving Mom alone with Rainey, now 15 years old. Unable to care for and maneuver Rainey on her own and having to provide income for herself, arrangements were made to have Rainey admitted to Zambarano Hospital in 1973. I do think that you should know that although Rainey was now awarded the stay, my mom, Dolores Demures, made it her life's mission to stay involved. Excuse me. She did so by volunteering 12 to 15 hours a week at Zambarano and occasionally at the Red Cross, all the while she kept a second shift job at the Ltch molding company. For her efforts over a 10-year period, our mom was recognized by the Rhode Island Assembly as Volunteer of the Year in 1983 and given an award by then Governor Joseph Garrahy. As for my brother Rainey, he has and he continues to strive in his Zambarano home. We as family members take such comfort in knowing that our loved ones' physical and medical needs are monitored by a qualified and caring medical staff 24/7. Although after what I heard tonight, I'm a little worried about that. Of equal importance are, and at least prior to the pandemic this was true, there are social activities afforded to the patients should they wish to partake. Some of these being church services, musical events, pet therapy, arts, crafts, movies, and field trips to fairs, malls, sporting events, and the like. Rainey is somewhat of a legend at ZAM, as he is almost always likely to say yes to any opportunity afforded him. My brother is a remarkable person, a kind, gentle soul with an ever-present smile. In short, an inspiration to those who meet him. In my opinion, he would not have become that person had he not been the recipient of the top-level care nurturing that his home at Zambarano afforded him. And that holds true for countless other patients that he has shared his home with. President Obama once said, "People with disabilities deserve the chance to build a life for themselves in the communities where they choose to live." My brother chooses to live at Zambarano and keep it as his home, and hopefully to see it staffed with the best of interest for all the patients in mind. Thank you very much for your time.
Richard, thank you very much, and thank you for presenting such the, I'll say, impressive story of your brother, and clearly your mom, your dad, your grandparents, and what they did for your brother. I'm sure he's better off because of it, as well as your mom and the countless hours of volunteer time she presented there. So thanks again for staying with us so long, Richard, and your input is much appreciated. Thank you. Hang on one second. Senator Dela Cruz.
Thank you, Mr. Chairman. Mr. Demers, it's so nice to hear from you. Thank you for hanging on for so long. And thank you for sharing your story. I could hear the emotion in your voice and your love for your brother and your family. And, you know, every time I see Rainey, he's always got a smile on his face. He's very happy to be there at ZAM, and the people there take good care of him. Thank you again for calling in.
Senator, thank you very much. And Richard, thank you again. We're down to our final three. Final two. Excuse me. Number 3 is not there. Good evening, Shirley. How are you tonight?
I'm doing well, and yourself?
Very good. And welcome to the Senate Oversight Committee hearing on Eleanor Slater Hospital. Thank you for being with us. It's much appreciated. We ask you to try and keep your...
Thank you for having me.
Thank you. Your testimony between 3 and 5 minutes. So we appreciate you waiting as long as you have. Over to you.
Okay. My name is Shirley Pacheco, and my son Adam has been a resident at Zambarano Hospital for the past 26 years due to an automobile accident. He had traumatic brain injury, and he's also a quadriplegic. And I really can't say enough about the care that he receives at Zambarano. Everyone that works there is so caring and so loving, and they everyone is treated like family. We are a family up at Zambarano, and I know so many of the residents there, and and the staff. Very sad about all that's going on, and I know a lot of family members are also. I don't know what we would do without Zambarano. It's I get choked up when I think about it. The staff is amazing. You can always count on them, to be there when you need questions answered. Anything that goes on with my son, they call me right away to let me know exactly what's going on, and you just don't get that anywhere else. And the thought that anyone would even consider closing the place, it's mind-boggling. I just don't get it. I just don't understand it. I had so many things that I wanted to say, and I just get so choked up.
Take your time. Take your time.
Over the years, there's been a few things that have happened, like the laundry has been taken away from Zambarano. And from what I understand, thousands of dollars a week are being spent on a laundry in town somewhere. I don't even know where this laundry is, but to me, that is money wasted that could have been put into the laundry facility that we had up at Zambarano. They just finished putting in all new windows in the building, a new air conditioning system. So much work has been done up there. It's like, let's just throw some money away. Why worry about it? Why worry about these people? Who are they? Why worry about the staff? Who are they? As long as we have what we need, what do we care about the staff or the residents up there? Mean nothing to us. That's the way I feel. I don't know if you or anyone else feels that way, but I feel like that they're just pushing us under the rug. No consideration for the families or the residents. And for so many of those residents, this is the only home they've ever known, the only family for a lot of them that they've ever known. Can you imagine what would happen to these people if all of this was taken away from them? This is their life. I don't know how else to put it. I know that I am going to fight as long as it takes to make sure that Zambarano stays Zambarano, and that all the residents there will know that their home is not being taken away from them, that they can feel safe and secure again with the wonderful staff that we have up there, the doctors, the CNAs, the nurses. They're all so fantastic. How can anyone even think about taking that away from these people? I don't know. I just don't know what else to say right now. It's been a very long day. And, being away from Zambarano for the 5 months that, visitation was shut down, that was so hard on my son and all the other residents there, due to the COVID and everything. And being back there, it's like being back with family, being reunited. When I go up there, I know I'm home. Everyone comes out, "Oh, Shirley, it's so good to see you again. We've missed you. Your son is doing so good. We're taking good care of him." And I can see it. I can see the care that he's getting wonderful care. And I don't believe that Adam would have survived if he had gone anywhere else. He would never have gotten the care anywhere else that he has received up at Zambarano. And that's really, at this point, that's really all that I have to say. I just hope that we keep fighting, everyone keeps fighting to keep Zambarano open, because we need that facility.
Shirley, thank you for being with us tonight. Thank you for the heartfelt testimony. I know we all do empathize with you with regards to the services and supports the patients and those who have lived at Eleanor Slater Zambarano for as long as they have, that they need to continue to receive the best care that they can receive. So thank you for being with us tonight. It's much appreciated.
And thank you so much for having me. I really appreciate all that you are all doing to keep Zambarano home, keep it there.
Just know that
I really appreciate it.
Just know that you and they are not forgotten by any means. So.
Thank you so much.
And will not be forgotten. Thank you.
Thank you.
Have a good night. Our final
You
call.
too. Thank you.
Thank you. Our final call for the evening, folks. Cynthia?
Yes.
Thank you for being with us tonight. Welcome to the Senate Oversight hearing on Eleanor Slater Hospital. We're glad you're with us tonight. We ask you to try and keep your testimony between 3 to 5 minutes, if you may. Thank you.
Okay, I will do that. Thank you very much. I did have some prepared testimony, but in lieu of that, I think if I could, I'd just like to respond to a couple of points that were raised by previous speakers.
That would be great. Thank you.
So by way of introduction, my name is Cynthia Lucier. I'm a registered nurse, and I am the president of Local 5019 of the United Nurses and Allied Professionals, which is the union that represents the nurses at Zambarano, as well as other state agencies. I worked at Zambarano actively as a staff nurse, as a charge nurse, and as an infection control nurse for 30 years, and proudly did so for all of that time. So I would just like, if I could go back, I kind of made a list as people came up. And the first thing that came up that I thought was incorrectly put before you was the notion that discharge planning has not been an active practice at the hospital. Nothing could be further from the truth. For as long as I can remember, I'm thinking back to the late 80s or early 90s, we had a plan in place, a team process, where all of the different disciplines, including patient family and the patients themselves, should they choose to attend, would meet at least quarterly or more often if necessary to talk about where they were, how they were progressing, if they weren't progressing, what we were going to do to address those things. It was truly a comprehensive development of a patient care plan. Part of that patient care plan from the admission care plan that was developed was to talk about discharge. Was it something that the patient was interested in? Was it something that we thought was feasible? Was that going to be part of what we did, was looking toward discharge in the future for that patient? And I'm pleased to say that oftentimes patients were discharged. It was when it was safe, it was when it was appropriate, and it was when it could happen in a manner that was good for everyone involved. In fact, staff would frequently contribute furniture, dishes, silverware, whatever the patient needed if they were going to an independent living arrangement or whatever they needed to make them successful. And so when someone says that there was not a robust plan for discharge, that's disingenuous. There was always an active discharge planning practice. I guess the second thing I would like to address is how we got to where we're not getting any federal dollars. And at one point we were told it was because of this IMD mix, the ratio was off, and so we fell out of compliance. And another time we're told that was not the case. It was due to other changes within CMS. Well, as being part of UNAP, we've been able to take advantage of speaking with some experts, and they are right now working on some issues, but they have told us they have never heard of anybody voluntarily withdrawing from the CMS program, and they said he couldn't remember the last time that anybody was ever kicked out of a program like that. What you would have to do is just submit a remediation plan as quickly as possible and and move on from there. So there's, we will have more information about that going forward. In terms of where we fit in the continuum of care, Zambarano has always found a niche. There's always been a place for us. When I went to work there, we still had TB patients, and there were 400 patients on the campus. And, we opened 4 group homes and successfully transferred some folks out. We then also had a certain population of the younger folks that was still there. But we've always found a place for ourselves, developed, more into the neurological diseases and traumatic brain injuries and that sort of stuff. A lot of people with respiratory illness would come and stay with us as well. And so, we've carved out a niche for ourselves. I guess where we find ourselves now is somebody from the outside is telling us that, we're not going to be an LTAC anymore. We're going to be a nursing home. And I think we ought to just say, stop for a minute. Let's take a look at, as Rhode Islanders, take a look at what we need. Let's do an assessment of what's needed within our state to care for our citizens. Nobody's done that. We hire, 8 or 9 years ago, they hired a company called AMS out of Boston. They came in, drained us for every nickel we had, and then moved along, wrote a nice fancy report and moved along, leaving behind salaries for all of the administrators that were doubled or tripled in some cases, and created new positions that we never had before, and hired new people into them, and they left. In between that, we've had, now we have the Alvarez and Marcel. We can't see their report because apparently it's top secret even though we paid for it. And we have a law firm that's been called in to speak to settle the claims with CMS. It's just, we're just spending and spending and spending, and the only people that are getting hurt are the patients and the families that need the care that gets provided at our state hospitals. There's a need for us. It's necessary, it's needed, and I think we need to just pump the brakes a little bit. Let's do a study, let's do an assessment, and let's do the right thing, not just bring in whoever the Johnny-come-lately to give us their ideas, and then they take the money and run. So I guess the only other thing that I did want to say is it gives me no pleasure to do this. I have always been so proud to have been an employee at ZAM and represent the nurses who do a fantastic job. Through this, especially through this last year, they have suffered. And they're frightened. They don't know what's going to happen. None of us do, because we don't get any information when we ask for it. We're not afraid of change. We're not afraid of doing something different. We'll work really hard to make it successful, but that's not what's happening. We're cut out of the plan, as though we're the ones who are going to make it work. When a patient at Zambarano rings a call bell, they're not ringing because they want an administrator to come take care of them. They're ringing a call bell because they need a nurse. I don't know what part of this, some of our administration has forgotten who it is that we serve and what it is that they need. And so I guess what I'm asking from you tonight is to maybe just, let's just stop the craziness. The plan that they presented to the House Finance and Senate Finance Committee was never approved by you all. It was never approved. But they're doing it anyway. So, I guess the question is, what would it matter? I mean, you didn't approve it, and they're doing it anyway. So I don't know. Whatever needs to happen, and I'm asking, you other people who can make it happen. And so, thank you for listening to to the ramblings of
Nope.
somebody who's been listening online for way too long tonight. And I appreciate your attendance, and I bid you a good night.
Cynthia, thank you very much for your testimony. With regards to the plan, it's just that. It was proposed by the previous administration. The current administration has also proposed something, but that's it. It's a proposal. It's now in the hands of the General Assembly to figure out what to do next. So we will move forward from here. We have quite a bit of testimony, both verbal and written, some both from some folks. A lot of questions. We got a presentation from the, Cynthia, thank you very much for being with us tonight. It's appreciated.
Well, thank you so much, Senator, and your fellow senators as well.
Thank you. So, committee, this wraps up our hearing on the hearing of oversight on Eleanor Slater Hospital. We've obviously heard quite a bit of information, gathered a lot of facts, a lot of data. It's now our job to figure out how we move forward with this. And at the end of the day, at the end of the hearing, I'd like to end the way we started. And you notice I never brought up the issue of money. I'm not going to bring up the issue of money now. It's about the patients. It's about Rhode Islanders. It's about individuals who rely on the services of the Eleanor Slater Hospital system, etc. How we, as a state, appropriately take care of those folks that need the services and the programs for which the Eleanor Slater Hospital system provides. And with that, I'd like to end the meeting. I'll have a motion by Senator Archambault to adjourn, seconded by Senator Acosta and Senator Dela Cruz. All in favor?
Aye. Aye.
All opposed? Committee, thank you very much. Thank you for the indulgence of the time. Much appreciated. Have a good night.